Since we've connected 329 Bloomberg Fellows, including 121 alumni.
And through these fellows, more than 300 collaborating organizations, to faculty and staff devoted to using evidence to make change.
What is a connection that matters for health?
It's not always the collaborations you might expect. About half of our community are
Please
non-traditional
welcome
partners
Director
for public
of
health.
From environmental protection groups and criminal justice systems, to urban planning and community development organizations.
From public schools and libraries to housing and transportation authorities.
We are bringing a public health toolkit to places far and wide.
From cities to rural towns to tribal communities.
What else can we achieve together through connection? New understandings to rethink old problems, new ideas to advance health and equity.
And new relationships for the challenges ahead. That's why we're here today.
We can make a difference to the trajectory of our nation.
Through the power of connection.
Please welcome Director of the Bloomberg American Health Initiative, Joshua Sharfstein, and Deputy Director of the Bloomberg American Health Initiative, Michelle Spencer.
Hey, good morning. No. Hey, good morning. Let's hear it for the Baltimore Urban Inspiration Choir. Josh, do you remember our very first Bloomberg American Health Summit?
The one in the dusty old schoolhouse, we could barely count the number of attendees on two hands.
That never happened.
Okay. The one where all we had for graphics was one whiteboard and two kind of half-used markers, and I played the violin for entertainment.
Ha, you played the violin for inspiration? Nope.
All right, the one where we could only imagine having a network of hundreds of fellows and organizations working to bring public health to some tough problems around the country?
Yes, that one. Look around. We now have 329 fellows from 42 states and the District of Columbia and 2 territories.
Yeah. And they clap so politely.
Yeah. Let me say it again. Okay. We now have 329 fellows from 42 states and the District of Columbia and 2 territories. Woohoo! Josh, did you ever stop to ask yourself how the initiative has grown?
How has the initiative grown? Is this a trick question involving sophists?
One connection at a time, Josh. One connection at a time.
I see, like, our original partners introduce us to new partners, and then our new partners become old partners, and then we have new partners.
You got it. Yeah, you got it. You got it. It's great when our fellows thrive in their classes. It's even better when they meet up and when they team up with each other and with our staff and with our faculties and again with each other.
Which brings us to this summit here in Baltimore, Maryland, and our theme of connection.
Today, we'll hear from policymakers, federal, state, and local officials. We'll hear from authors and journalists, and from a diversity of leaders within our own network of practice collaboration organizations.
We want you to be sure to meet people from different states, different focus areas, different perspectives. You should talk about opportunities to work together.
And we want you to spread the word, to create new connections with others that are not in the room.
There's only some way to spread the word.
Before we go any further, we have some acknowledgments and thank yous.
As we gather from places across the country, we honor and recognize the indigenous people of our homelands. We humbly acknowledge that Johns Hopkins University is located on the traditional and contemporary homelands of indigenous peoples, including the unceded lands of the Piscataway and Susquehannock peoples.
We recognize the enduring presence of more than 7,000 indigenous peoples in Baltimore City, including Piscataway, Lumbee, and the Eastern Band of Cherokee community members.
Together, we acknowledge the history of genocide and ongoing systemic and health inequities while respecting treaties made on this territory as a step toward reconciliation and strengthening relationships and partnerships with indigenous peoples and their communities.
We give thanks to the past, present, and future stewards of this land, and respect all tribal nations' sovereignty and right to self-determination. We aim to hold ourselves and the university community accountable to all tribal nations.
And at the Bloomberg American Health Initiative, we're proud of our strong partnership with the Center for Indigenous Health, which has led to more than a dozen projects across the country and more to come.
Now to some thank yous, starting with Dean Ellen McKenzie of the Johns Hopkins Bloomberg School of Public Health, and extending to other deans and chairs, faculty, staff, and students.
Now, believe it or not, this event does not come together spontaneously. So hard to imagine, I guess. But we really appreciate the teams at Production Glue, the Baltimore Marriott Waterfront Hotel, and Subject Matter, as well as this incredible staff of the Bloomberg American Health Initiative, including our, looking for a superlative here that captures it, it's hard.
Of course.
Extraordinary Administrator Akola Francis, and our phenomenal producer, Shannon Jones.
And thank you to Bloomberg Philanthropies. We are so grateful to Patty Harris, Kelly Henning, Allie Jeffrin, Jessica Layton.
She gets two
Jessica
mentions.
Layton.
Yeah, okay, she
Okay,
gets
three.
a few mentions. Yeah.
Cindy Tom, Jess Valet, and Veronica Lewin.
Wait a second, is there someone from Bloomberg Philanthropies we might be leaving out? Maybe. Well, we thank Mike Bloomberg for making it all possible. Let's hear from him now.
Hello, everyone. Welcome to the 2023 Bloomberg American Health Summit. As we get started, I just want to thank Josh Sharfstein, Michelle Spencer, Ellen McKenzie, Ron Daniels, and the extraordinary faculty, fellows, and the team behind the Bloomberg American Health Initiative. Every year, this summit convenes the doers who are confronting America's most persistent health challenges and saving lives, hand in hand with communities and partners nationwide. And that work isn't easy, especially as public health has become a political football, and more elected leaders are afraid to follow data and evidence. The political courage to do what's right for public health has always been in short supply, but we know progress is possible. New York City proved it when we took on tobacco and obesity and gun violence. Across the country, the Bloomberg Fellows are proving it with the interventions that they're advancing every day. Working across disciplines to secure victories for public health is what this initiative is all about. Millions of people owe their health to the great work everyone here is leading, so keep it up. Thanks again. Have a productive week in Baltimore, and all the best.
Please welcome President of Johns Hopkins University, Ronald J. Daniels.
Good morning. Good morning. Good morning. It's great to see you all here. Thank you, Mike, for your moving words and your enduring, and indeed truly visionary support for this initiative. Josh and Michelle, a comedy team. Who would have thunk it? Don't leave your day job. These guys truly have been amazing in terms of the energy, the imagination, the irrepressible enthusiasm, the attention to the small details while driving a big agenda. You guys are extraordinary, and I just, again, on behalf of all of us, want to thank you for your incredible, incredible leadership of this initiative. So, officially, I'm delighted to welcome you all to the 6th Annual Bloomberg American Health Summit. From its earliest days, the field of public health has been defined by the connections its practitioners have drawn. Connections between facts and theories, between biology and society, between people and policy. Now, a perfect case study, and I love the case studies. There are so many wonderful case studies you can draw from the history of public health in this country and beyond. But a perfect case study of this began in 1906 as a mysterious and deadly disease known as pellagra swept through the American South, eventually affecting more than 3 million people and killing nearly 100,000 people. Symptoms of the disease included debilitating skin rashes, gastrointestinal inflammation, and even dementia. The disease had plagued European farming communities for nearly 2 centuries, but its origins continued to baffle the scientific and medical communities. By the time it arrived on American soil, many experts believed that pellagra was, to quote one of them, a sphinx of which we have asked a reply and gotten none. Enter Joseph Goldberger, a physician in the U.S. Public Health Service. Goldberger was the first person to successfully recognize that cracking the Sphinx's riddle meant looking for connections between pellagra and social determinants of health, like poverty and nutrition. He discovered that those who suffered from the disease also lacked nutrients, like niacin. Pellagra was not only treatable, but indeed preventable. But to ensure that this disease was prevented required that his findings be connected to public policy. Those who followed in Dr. Goldberger's footsteps helped link his insight to a suite of national campaigns and federal policies, including the widespread enrichment in flour and other food products with niacin and the first dietary recommendations for daily nutrients. Today, pellagra has been virtually eliminated from the developed world. Its near eradication is evidence of the power of public health practitioners to connect biology and medicine to a range of interventions and policies for a healthier society. This example, this ethos, lies at the very heart of the Bloomberg American Health Initiative. Since its founding, we have connected more than 300 fellows, over 100 alumni, and over 260 organizations across fields, disciplines, and regions to solve seemingly intractable problems. The sphinxes, so to speak, of addiction and overdose, climate change, adolescent disconnection, violence prevention, and our nation's food system. And now, thanks to the newly opened Johns Hopkins University Bloomberg Center at 555 Pennsylvania Avenue in DC, we're able to advance this work at even greater scales as we bridge brilliant evidence-based scholarship and interdisciplinary collaboration with impactful policymaking that serves and sustains our hope for a more equitable, a more just, a healthier world. I'm proud that Johns Hopkins, working alongside our partners at Bloomberg Philanthropies, is able to support this vital work together with your leadership, with your energy, with all the work that you're doing. We will continue to forge new and uncharted connections that will reshape the course of public health in the 21st century. Thank you all for being here, and enjoy the summit. Now, it's my pleasure to welcome to the stage a public health expert, pediatrician, and devoted and indeed highly accomplished public servant who has devoted her career to providing equitable access to health care for all people, Deputy Mayor for Equity, Health, and Human Services for the City of Baltimore, Dr. Letitia Jarrasa. Dr. Jarrasa.
Good morning, everyone. Thank you so much, President Daniels, for that warm welcome. As stated, my name is Dr. Letitia Gerasa, and I am the Deputy Mayor of Equity, Health, and Human Services here in Baltimore City. It is truly a pleasure to bring greetings and a warm welcome on behalf of Mayor Brandon Scott. I'd like to start by also thanking Bloomberg Philanthropies and the Bloomberg American Health Initiative for inviting me to be a part of their summit. I want to acknowledge all of the amazing Bloomberg Fellows in the room that are serving throughout Maryland and across our country. I am particularly honored to give a special recognition to the Bloomberg Fellows who are working throughout Baltimore and city agencies, including the Baltimore City Police Department and my former home, the Baltimore City Health Department, as well as those who are serving in community-based organizations and social service organizations like House of Ruth Maryland. As I reflected on this year's theme of connection, I was encouraged by just how apt and timely this topic is. And what I hope is a paradigm shift. We are seeing the country at large, and Baltimore more specifically, break down traditional organizational silos. I believe this intentional shift will better allow us to collectively and collaboratively create innovative solutions that address the social determinants of health. Challenges like the upsurge of violence among youth have been felt throughout our country, and the Scott administration has doubled down on a multidisciplinary approach. Instead of leading with punitive measures, the Scott administration has chosen to address violence using both a public health and equity lens. Through that lens, we are co-creating a progressive and multifaceted plan to reduce violence amongst youth. In my former position as the Baltimore City Health Department, I was tasked with leading the creation of the mayor's comprehensive violence prevention plan in September 2020. Now, in my current role as deputy mayor, I have been entrusted with bringing that same public health perspective as I lead the development of the Youth Violence Reduction Framework. This framework, by design, is very intentionally centered around youth voice. Baltimore City's youth inform the topics and the themes which all of the recommendations are based. The guidance they provide will ultimately be integrated into Baltimore's existing comprehensive intervention ecosystem, a system that already engages more than 13 community and hospital-based partners across the city. It is my hope that Baltimore will continue to be a leader on the national stage as we demonstrate the importance of interconnectedness when addressing a wide range of social issues. Thanks again to the work that you all as fellows are doing here in Maryland and across the country. I know that we will continue to see public health advance as an integral part of creating safer, more equitable, and thriving communities throughout our nation. Your various fields of work, whether in education, social justice, community development, or healthcare, are so critical to bringing fresh and unique perspectives as we take on some of the nation's toughest public health challenges. Thank you again for inviting me here today to kick off what I know is going to be an amazing summit. Now please join me in welcoming Josh and Michelle back to the stage.
Okay, just a quick unscripted moment here for us to express appreciation to Dr. Gerasa, who has been the health commissioner until very recently in Baltimore, all the way through the pandemic. Mm-hmm. She is known for two things. One, and not in this order, her incredible footwear. And second, for her incredible leadership during the pandemic, which included so many community meetings of every kind and size, where she brought her pediatrician calm to so many crazy situations. She created a community health workforce of hundreds of community health workers. She developed a public-private partnership with major institutions in the city that stood up hotels that were for people who didn't have housing. I could go on and on. A huge coalition of nonprofit organizations, faith community, focused on areas of the city people going door to door to get good information out on vaccines. And we actually looked and compared Baltimore to similar counties, and Baltimore was at or near the top for cases, deaths, and vaccination. I think top 3% for vaccinations. I would like to ask you all to join me and Michelle in a tremendous thank you to Dr. Terraza.
Don't forget her communication strategy.
Yeah, okay. The communication strategy was great too. Okay, so.
Okay, sorry. It was so great to hear from Mayor Bloomberg and President Daniels, whose continued consistency and strong support for the initiative is so very much appreciated.
Okay, and now we get to go to the heart of our program, speakers and discussions in our 5 areas of focus. We're going to start with adolescent health, and then environmental challenges, violence, addiction and overdose, and food systems for health.
And we'll hear from community members, local, state, and federal officials, expert researchers, and others
about how to advance equity, where to find key evidence, and which policies can make a big difference.
So please take the opportunity to engage on social media using the hashtag Bloomberg Health Summit 23.
And there's also the, I think, Bloomberg Health
Summit 2023.
2023,
I
very
want to
good.
make sure you're paying attention.
Okay, good. There's also the app, which I still haven't been able to download, but I will work on it.
So let's get started. Let's get started, Josh.
We're going to start with a video about our fellow Edward McWilliams of the Center for Justice Innovation,
which recently received an $8 million unrestricted grant from McKinsey Scott.
I'm Edward McWilliams. I'm the Associate Director of Planning and Development for the Center for Justice Innovation, working specifically at Neighbors in Action. Neighbors in Action works to make the central Brooklyn neighborhoods of Bedford-Stuyvesant and Crown Heights safer and healthier for everyone. Been operating out of a storefront since 1998. Neighbors in Action seeks to promote community cohesion. We connect residents to resources for parenting, education, housing, and immigration. We support young people navigating the challenges of poverty, drugs, and violence. And we galvanize neighborhood stakeholders to improve the quality of life for all residents. In my fellowship, I've learned enhanced research abilities, strategic planning capability, grant writing, program evaluation, and project development. I felt empowered as an expert in this particular field with an ability to contribute to knowledge of adolescent health and youth development given my 17 years of experience in the field. As a Bloomberg Fellow, I've had the privilege of building a diverse network of professionals, researchers, and fellow students in the public health field. At last year's summit, I got to connect with other fellows working here in New York, and we still talk and meet frequently to discuss our work, study, share experiences. This expanded network has opened doors to collaborations and partnerships that have broadened our organization's reach and resources.
Please welcome co-founder of the Granny Project, Brianna Dabney, co-founder of the Granny Project, Amaya Murillo, volunteer with the Granny Project, Ganita Wallace, for a conversation with founder and executive director of Heart Smiles, Joni Hollyfield.
Good morning. Good morning. Let's get right into it. Bree, Tell us about the Granny Project. What is it?
So the Granny Project is a youth-led and youth-founded project founded here in Baltimore to basically fight food insecurity within Baltimore City. So in order to start this project, or in order to make this project, we have community leaders, or not even leaders, but just community members be grannies or cook demos, and they cook demos. Go ahead.
We basically are able to kind of provide people with a tutorial as to how to prepare meals. So the cook demos, they kind of started more when COVID had hit. We were able to kind of turn our original idea that came through the Youth Advisory Board with the Center of Adolescent Health with Bloomberg Public School of Health. And we basically were able to take like 50 different ideas and kind of like mix and match and see what kind of worked, what didn't work. And then over the course of like some time, we were able to figure out that the Granny Project was actually the best idea to go with. And then in 2018, during YouthWorks, we actually had a group that kind of took that idea and tried to place it in a way where we were able to figure out how it actually would look in the real life sense. And after that idea kind of got like finalized, COVID had hit, so it kind of took like a little hit on our idea to do in-person cooking shows. So we took it to YouTube Live, and we're able to actually do like a whole live stream where we would have a granny come on Zoom with me, and I would host, and then they would be able to prepare the entire meal, and everybody would be able to listen in and watch and follow along. And we are able to provide 20 to 25 families with meals to be able to participate with us.
Okay, that's a lot. Thank you. That's a lot. Talk to us a little bit about the team. Amaya, tell us what the team looks like.
So as of right now, it is me and Bree. The main people that are on the team that are like running things. Over the course of the couple years that we've been doing this, we actually kind of had like different teams throughout the time. Our first team, it was me, Bree, someone named Summer, we had Lamar, and then we had Corey on our team as well. And we kind of had to figure out what jobs everybody would be able to do, and just kind of mix and match. It was a lot of trial and error, a lot of learning lessons that we had throughout. But so far, me and Bree have been the two that stuck and have kind of been running it on our own since.
And the team were all young people?
Yes, all youth led, yep.
Okay. Ms. Wallace, how and why did you get involved in the Granny Project?
I got involved because I realized how important it is to have this type of project. I witnessed some young children that they didn't speak English, trying to get food out of a dumpster behind the school that I worked at. And I beckoned them. I could not speak their language, but they understood when I did this, because this means eat. And they mimicked me, like we wanted something to eat. I got the principal involved, we got some interpreters, and we were able to get the children in school. I see firsthand the children in need, and I think this is a great project. We had an 8th grader, he was an A student, and I always watched him collecting everybody else's food. Are you gonna eat that? If you're not eating that, he would wrap it and put it in his book bag. And I was saying, what is he doing? And to come to find out, he told me, he said, my mother and my uncle are on drugs, and I gotta eat at night. And that was the way he was getting dinner at night. I've seen it firsthand that the young people are lacking. These are our future mayors, our governors, our doctors, our nurses. And if we fail them, we fail ourselves.
Thank you, Ms. Wallace. Thank you. Bree, can you talk to us about what the response has been from the community? Because it sounds like you guys have been doing this for a while now.
Yeah, the community response has been great, very overwhelming actually. People really love it, and people look forward to, being able to be a part, being able to be either a participant or just help us in any way that they can. Since we do involve a lot of youth would love to come, help us pack, help us, deliver and things like that, or even just interviewing the grannies, being part of the videos, and cooking different foods. It's really great, so.
Ms. Wallace, can you tell us a little bit about some of the meals you've been able to provide and why those were important to you?
Oh, yes. In 2020, I worked with the National Guards to help feed the youth, to make sure that during COVID, this was before the food stamps, before the stimulus, when the stores were limited in food, I helped to feed them and helped to make sure that they had something. We had an older Jewish gentleman. He donated the food. It was called a weekend bag, and he made sure that we had enough food, cereal and pastas in a can that all the kids had to do was heat up. They had crackers. They had enough food until we opened back up on Monday. This
What about
older
through the
gentleman,
Granny Project?
Yes, the Granny Project, I prepared a meal that the young people can do on their own. If mama's at work and they have their siblings, they're able to put together a meal to last until mom gets home. It's a very important project. So many teenagers are responsible for their siblings, and if they can prepare a meal, an inexpensive meal at that, even if they got the food from the food bank. In fact, one of the meals I prepped, if the food bank gave them that, they could take it home and prepare a meal for their siblings.
And I hear somebody asking me, what meal was that though?
It was a, it was a beef casserole. It was a beef sausage casserole. It included broccoli, pasta, cheese, and the meat. And so they had everything in that one dish, and it's delicious.
Yeah. I love it. Amaya, can you talk to me about maybe some of the partnerships that you guys have had with the Granny Project? What was that like?
So recently, well, not really recently, but within the last 2 years, we actually have been working with CASA. They actually asked about the Granny Project. They heard about us, and they started kind of asking some questions. And from what they were hearing, they really loved what we were doing. And they actually asked if we would be able to partner with them. So once we were able to get a grant to fund it, we actually were able to kind of take our Granny Project that's more like Americanized, and we're able to turn it into like a Latinx partnership where they're able to cook Spanish traditional, meals.
I love that. I love that. Ms. Wallace, why do you think this kind of education around food and eating is so important for our communities?
It's important because without the proper nutrition, it's hard for children to learn. You can't teach them math or algebra and they're hungry. Their mind is on, I need something to eat. I need my nutrition. And we all know what nutrition does to the brain. And so we need that. And so I'm just glad that this project is available. It's very important. We need our young people. We need them to develop properly.
Thank you. Bree, lessons learned. Talk about the lessons you've learned through the Granny Project.
Lessons learned. I've learned that youth-led, in order to be truly youth-led, it's definitely not easy, and I'll just say that. I think that a lot of times when people say youth-led, youth are there, but they don't necessarily have a voice, or they are not necessarily doing the work. So to have youth actually doing the work is definitely an adapting, experience. You have to adapt, you have to know, because it's nothing really to go off of. We are our blueprint, if that makes sense. So yeah, just definitely learning how to navigate that, I think, was the biggest learning experience. But.
All right, Amaya, be real with us. You can spill all the tea.
I can say what I want to say.
We want to know.
Okay. I would say, for me personally, a big thing that I took away from the Granny Project is leadership is something that is not as simple as I feel like people say, be a leader. It's really not that easy. The Granny Project, I've had to have lots of hard conversations with people, and I told you guys how, we had teams, didn't seem to work out. We had like 3 different teams before it kind of just came down to us. So throughout that process, trying to step up and be a leader and do like 5 people's jobs at once was definitely, I think, something for me that I was like, wow, this is a lot. But I took it, me and Bree both took it, and we took on the jobs together, and were able to really come out and make something great out of it. But definitely picking your team is wise, and trying to not like, I would say take initiative to be a leader. I feel like at first I was very scared too, because I was like, I don't want to do anything wrong. I don't want to make the wrong step or the wrong decision. But, you know, I think ultimately taking that initiative really helped kind of get things to roll. So I would definitely say leadership was a huge thing that I had to learn throughout this process.
Yeah, no, and I definitely can understand that. When you talk about the team, right, when you say, oh, it's just you and Bree, some people might think it's just y'all doing everything.
Oh, yeah.
Can you talk just a little bit about some of the different roles and how some of the other young people are contributing to the Granny Project?
Yeah, so we leave it kind of open for everybody to give us ideas. It's definitely not one way set in stone, you know what I'm saying? But also with our packing, so that's all youth. We are kind of more of like the managing side, so I might go, since I run the budget and stuff, I might go to the store, get the food and everything, but they're packing, they're making sure all the ingredients are in the bags, they're giving the bags out to the other community, people in the community and things like that. And then just giving us ideas as well as like, okay, well, what would you want to, you know, cook with the granny, things like that, yeah.
Yeah, I would say another thing that to take into account, we have outside of like the people that we have packing, which before it was more so our team that we had before, of our people that are through Heart Smiles as well. But right now, the people that we are having pack and, you know, hand out the bags and who are in the videos, also helping the grannies cook, which is really great, are the youth that we have from CASA. So, and then a couple of the people that we've kind of recruited and that are already heartbeats with us. So we definitely have had a lot of youth involvement outside of us as well, that are really a big part of how we can make things happen. Because without them, like I said, me and Bree would be really doing everything again by ourselves.
Yeah, I just want to add on, not only is the project helping people like with food insecurity, but also the students that are getting paid, they're getting good stipends. The grannies are getting good stipends. I remember one granny kind of was like really thanking us so much because it had helped her pay her rent. So it's definitely helping different aspects of the community, not even just with the food. But
Thank you. Yeah, and Ms. Wallace, in 20 seconds, can you tell us what the experience has been like for you?
I really enjoyed it. The ladies did all of the shopping. That was the big thing. All I had to do was show up and prepare the meal and cook, and it was a really good environment. And I just love the fact that this idea is, I just wish it would go global so that we could help all of the youth.
Yes, yes. And I'm going to give you all 5 seconds each for a last word. Bree, let's start with you.
Oh, well, first, shout out to Miss Tamara Mendoza and Dr. Kristen Mari. Both of them are doctors, but definitely shout out to them because we probably never would have even been able to come out with this project if it wasn't for them bringing up food insecurity. I wasn't aware of that until they brought that up to us. So definitely a thank you to you guys, and thank you to everybody who's here.
So Amaya, you got 1 second now.
Okay,
sorry.
1 second. Okay, thanks. I would say that definitely be aware that we are a project where we are grant funded, and in order to help other people, we definitely continue needing more money and more grant money so that we're able to help the community.
Half a second.
Let's get a van, let's do weekend bags, let's park in front of some of these schools where we know these children need enough food just to get them back to school Monday. If we can feed them in the weekend, we can get them back on Monday.
Thank you all so much. This has been a great discussion. Thank you. Thank you all. And next up, we'll be moving to a discussion about rethinking juvenile system, moderated by Karen Desai, Executive Director of The Imprint, a nonprofit publication that covers child welfare and juvenile justice.
here today. Well, I'm very excited to turn the floor over very shortly to Imhotep, who is a youth development practitioner who has worked here in Baltimore and as a Peace Corps volunteer in Ecuador. So he has a breadth of experience that's global. You guys are going to learn a lot from hearing from him. I just want to say briefly, as an investigative reporter and a journalist and now an editor who's covered youth justice for 20 years in this country, the old conversation about crime and punishment is now a public health story. We've had a dramatic shift in the way we view how we fight crime, and it's rooted in history. It's rooted in historical trauma and intergenerational trauma, systemic racism, entrenched poverty. All of these things play into crime, right? And when we revision that, we treat youth in their communities and in their families and among people who love them and care for them. And then we have a safe society. So just finally, I'll just say that 20 years ago, when my first investigative project was on the California Youth Authority, which at that point was the largest youth prison system in the nation, possibly the world, with 10,000 children and young teens incarcerated. In June, it was shut down. So this is a really cool conversation because you have seated before you here a youth development practitioner. And if you can just tell, I'm really curious, and I'm sure these folks are as well, what is that? Tell us some more about that role.
Sure. So I think a youth development practitioner is a really cool jargon or technical term just to kind of convey and impart an individual myself who has lived experience kind of overcoming some of the circumstances and challenges faced by the population we're referring to, youth and young adults between the ages of 16 and 24, but who's also kind of learned notable lessons as it pertains to some of those challenges, and as a result, who has kind of dedicated a notable portion of his career thus far, going on 13, 14 years-ish, depending on if you consider like high school and when I didn't necessarily have a resume, to really just uplift and complement youth as they kind of go through their respective journeys to add value and really amplify some of the assets they have as fellow humans with their own respective capabilities and strengths.
Absolutely, and I think it's really important to note like what the definition of youth has become, because with the additional brain science and all that we've done with brain imaging and adolescent medicine, we really know that youth and the frontal lobe development does extend well into their mid-20s. So at the Imprint, which is our nonprofit news outlet, we call youth folks who are well into their 20s and even pushing 30 sometime, and I know because I have adult children. Can you talk about this notion of disconnection, which is a kind of a buzzword, but as it pertains to your work, how would you define the disconnected youth of today?
Sure. So that's a great question. I think when we were kind of talking through this, prior to kind of doing some research, I was like, disconnection from what? I feel like it's pretty obvious from the juvenile justice system. However, after doing my due diligence in a public health lens, I think it kind of refers to this population again, once again, youth and young adults between the ages of 16 and 24 being disconnected from school and work. And so I think when thinking about academics and the school component, I think that unfortunately, and I'm sure like research kind of backs and support this, that when youth, essentially they aren't essentially excelling in academic settings, unfortunately, due to, a lack of adequate support in the home and academic settings for a variety of reasons, unfortunately, this kind of contributes to disconnection from those academic spaces. And I think that, unfortunately, when there is a disconnection, youth and young adults then kind of return to their communities. I think this is also amplified by the fact that when you're 16 to 24, there is an abundance of responsibilities, right? So as the previous panel shared, pardon me, you know, youth and young adults are siblings, right? And therefore they have to care for younger ones. As you become a youth and young adult, there are so many competing priorities. You obtain expenditures, whether that's, you know, a cell phone bill, if you're an artist, entrepreneur trying to invest, not to mention just basic upkeeping, right? We all want to be dressed to the nine and respectfully presentable, and not to mention the notable reality that they're also parents occasionally. And so when you think about these factors, a disconnection from school, competing responsibilities, and returning to your communities where you may not have the idealistic, positive and healthy adults, I think that occasionally youth and young adults kind of become engaged in informal economies occasionally. And these are tangible things that are in their communities because sometimes the doctors, lawyers, and so forth aren't necessarily there to provide that counsel. They engage in what's tangible, and this kind of correlates directly to system involvement.
Right, right. And what are the approaches that you found to be most successful with re-engaging or complementing the youth to overcome some of the obstacles that sounds like are really deeply entrenched in poverty a lot of times?
Certainly, and I apologize, Karen, if I may just backtrack for one brief second
Absolutely.
before addressing your inquiry. I think it's really notable to also flag, I think I forgot the component as it pertains to work. I think there's no mystery that when youth and young adults kind of become system involved, thinking about the work component, I think pre-system involvement, there's this kind of confliction between low wage returns as it pertains to basic blue collar opportunities. We're in a blue collar city, and the competing perceived notion of high wage returns in informal economies. I think that's the pre-system involvement notion. And then post-system, I think it's kind of some of the hindering challenges of probation and parole that hinder where you can go, the extent in which you can stay out when maybe working blue collar roles, such as the people who are complementing all of us here to obtain our coffee, tea, and whatnot. And then in addition to that, I think it's the kind of notable component of just a lack of workforce skills due to confinement and such, and not that holistic kind of root cause approach being poured into them. And then lastly, it's just a kind of component of a lack of formal education due to that system involvement in it as well. Sorry.
No, that's
I
cool.
wanted to address that.
Please.
But yeah, when thinking about some of the practice, two things come to mind. I think group and one-on-one mentoring has been a kind of preferred tool of choice when thinking about enhancing the life skills and leadership development of youth and young adults, but also restorative practices. I think those are the two principal tools that have been complementary, and I think it's also notable to be mindful that when I think a lot of times in the systems component, things are very much punitive as opposed to focusing on the root cause and restorative. And the last thing I'll just flag is that I think when thinking about the demographics and the populations who compromise a fair majority of the systems, these are people who fit into the jargon of BIPOC, Black, Indigenous, people of color. I think that a lot of the punitive practices aren't necessarily aligned with some of the ancestral practices of those people that are much connected to indigenous and restorative practices, and so there's a disconnect.
I don't think anyone could have said it any better. Thank you so much. And
thank you.
Fortunately, we're out of time, but you nailed it. So thank you. Thank you. They are not playing with these time frames. They're very short. And we also lost a panelist, so I'm glad that you have more time. Thank you very much. It was really my honor to speak with you today. Next, we have another distinguished panelist, Dr. Christian Mari, who will discuss her project, Vital. So thank you.
is well known that people living near vacant lots have poor health, research shows that greening them, which can include removing trash, mowing grass, and creating gardens, can reduce crime and violence, improve neighborhood safety, and even promote the mental health of those who live nearby. Yet most of this research has focused on adults instead of adolescents, even though adolescents have very different experiences and perceptions about their neighborhoods compared to adults. In Baltimore, there are over 20,000 vacant lots and an additional 17,000 abandoned buildings. Approximately 900 of these spaces have been greened. To examine whether greening vacant lots can influence the health of adolescents, Project Vital was launched nearly 3 years ago, thanks to an award from the Bloomberg American Health Initiative. As part of this study, we have developed a database of vacant lots that is maintained by the Baltimore Neighborhood Indicators Alliance. The data is geocoded, which can illustrate not only where these lots are located, but whether and how they've been greened. We are also conducting a mixed methods study that includes surveys among adolescents, observations of both greened and ungreened vacant lots, and in-depth interviews among adolescents who live next to different types of green vacant lots. This data will provide us with critical evidence to understand whether greening vacant lots can be an effective strategy for improving the health of adolescents in Baltimore. Now, let's shift gears and move to another focus area, environmental challenges. To start, let's take a look at this video featuring Bloomberg fellow Mescal Vasquez.
I'm Miguel Angel Vasquez. I'm the Health Equity Urban and Regional Planner for the Riverside University Health System Public Health. I serve all Riverside County, which includes 28 cities, 43 unincorporated communities, 12 sovereign Native American tribes, and 2.5 million people. I work on the integration of urban planning systems and public health practices to improve health outcomes countywide, especially in communities with the greatest needs and environmental challenges. A good example is the work we've done with the California Endowment's Building Healthy Communities Initiative. We assembled an amazing network of community champions who represent the public, the private, and nonprofit sectors, and we work together to make our communities stronger, healthier, and more equitable. Being a Bloomberg Fellow is an amazing opportunity to amplify and accelerate my work. I hope to inspire other built environment professionals like city planners who have yet to discover the role they play in improving public health. Networking and collaboration are at the heart of what I do. The fellowship program is helping me connect with other like-minded organizations towards a shared goal of community development with public health at the center.
Please welcome Director of the Office of Climate Change and Health Equity at the United States Department of Health and Human Services, Dr. John Belbis.
Good morning, everybody. I want to give a huge thank you to the organizers and colleagues here at the Bloomberg American Health Summit. I'm very grateful to have this opportunity to speak with you this morning. Let me just start by acknowledging, all of us acknowledging, that we are in hard times right now, and we are all in need of hope. And maybe I'm just going to take a big sigh standing up here. We can all take a sigh together and pull our hope and our compassion for what's going on in the world around us, the war, the strife, etc. And it's November, but the summer of 2023 was also a really hard time. As the Earth's temperature soared to record-breaking levels, we learned once again that climate change is harming our health, with the impacts disproportionately affecting those already experiencing the short end of health disparities. And sadly, after this summer, we can put new numbers on these disparities. We learned that out of 425 deaths that occurred because of heat in Maricopa County, that's where Phoenix is, in 2022, 425 people died. 2/3 of those deaths involved substance use. 90% of those, or over half of the total deaths, involved methamphetamine, striking numbers. And the number of deaths in Maricopa County has soared well beyond 425 this year with the heat of 2023. Of the 13 people who died when the remnants of Hurricane Ida struck New York and New York City, 11 of them were recent immigrants in poorly maintained underground apartments. John Holdren, former director of the White House Office of Science and Technology Policy, famously said that when it comes to climate change, we basically have three choices: mitigation, adaptation, and suffering. And we're going to do some of each, and the question is what the mix is going to be. Those are his words. What we've lived, our experience this year, is that because we as a society have failed so far to mitigate or adapt, suffering is dominating the mix. But it doesn't have to be that way. And here's my bottom line. The health sector is essential to reducing the climate suffering of disadvantaged populations. But it's not going to happen magically. It will happen by the health sector showing extraordinary leadership, not just in providing care to those suffering, but through health system mitigation and resilience. Bear with me on this. The health sector represents over 20% of the nation's GDP. It's often communities' largest employer, and it also contributes about 8.5%. I'll say that again, 8.5% of the United States' total greenhouse gas emissions. In order for health to find its rightful place as part of the climate solution, it seems like we have to stop being such a big part of the climate problem. 115 institutions so far, comprising 1 in 6 hospitals across the country, and many Fortune 500 pharmaceutical group purchasing organizations, medical device manufacturers, etc. We've brought together the U.S. federal health systems, including the Defense Health Agency, the Veterans Health Administration, the Indian Health Services, the Bureau of Prisons, and we're developing clinical guidelines for all the clinicians in those systems to help reduce the greenhouse gas emissions associated with care in them. We're launching a catalytic campaign to collect rural and safety net hospitals and community health centers to financial resources that will give them renewable energy systems and health system microgrids, as well as other resilience measures through the Inflation Reduction Act and the funding available in their programs. And we're supporting community-led climate resilience centers that embed healthcare services in a suite of human and social services to provide year-round support for disadvantaged communities, as well as providing a critical refuge in times of crisis. The opportunities here, to me, are very exciting. For example, how many of you know that the wasteful use of anesthetic gases can contribute as much as 40% of a hospital's direct greenhouse gas emissions? That's the anesthesia that they use, 40%. That one type of anesthetic gas, desflurane, has over 2,500 times the global warming potential as CO2. And the rest of them are not good actors, much more than CO2 as well. In published studies, innovative use of electronic medical record data to give real-time feedback to anesthesiologists has resulted in a 50% or more reduction in the emissions of those anesthetic gases within just a matter of weeks. This not only helps save the planet, it saves the hospital money. Maybe even more exciting is work we're doing with partners like the CHARGE Partnership. CHARGE Partnership brings together the National Association of Community Health Centers, a community finance organization, and a designer and installer of solar energy and health system microgrids. The result? Low-income communities get direct investments, frequently not just for the health system or the health center, but also for residents. They get a climate-resilient health center that can serve as a refuge in a disaster, and they get a community health center that has more funds to put to patient care. This is just a taste of how our office is approaching its mission to protect health in the United States from climate change, especially for those most vulnerable. But would you agree this tastes like hope, like optimism, like activism, and like social equity? I hope so. So this is the message that we're bringing to the first ever Health Day at COP28. Climate action needs to be embedded throughout the practice of medicine, social services, and public health. The actions must include both resilience actions and greenhouse gas reduction actions. Once we've achieved that, we will not only be well on the way to bringing more equity to communities suffering from climate change impacts, but the health sector will have something more tangible and concrete to bring to the climate policy discussions. It's not enough for health to just demand a seat at the climate table. By taking the path of leadership and making climate actions routine throughout all of our institutions, we will have earned that seat. Thank you for your time, and it's now my honor to introduce the next segment of our program. Please join me in welcoming Bloomberg Fellow Michelle Mabson and Charles Lee from EPA's Office of Environmental Justice and External Civil Rights to the stage, and thanks again for your attention to my talk.
Well, good morning. It's such a privilege to share space with you all today. So my name is Michelle Mabson. I'm a current Bloomberg Fellow. I'm a second-year DRPH student in the Environmental Health Tract. And I'm also a staff scientist at our nation's largest environmental nonprofit law organization called Earthjustice. So I want to turn to Charles Lee, who is the Senior Advisor in the U.S. Environmental Protection Agency's Office of Environmental Justice and External Civil Rights. It's a mouthful, excuse me. But it is truly a privilege and an honor because Charles is among the founders and really, I would say, a vanguard of the environmental justice movement. And it is really his work to help to ensure that communities have a space, have a voice at our highest level of decision-making in our government. That is a part of some of his accomplishments and what we'll be discussing today. And so we have a pretty enormous task of discussing structural racism in the environment. We could talk about this throughout the entire summit, and in some ways I hope we do. I hope that this can spark a conversation about how we can look at institutional practices and policies that impact both the spaces we all work in, but again, are built in natural environments. And so I'm going to ground us very briefly and then turn to Charles. So when I think about structural racism, I think it is part of the very fabric of our nation. It is, again, these institutional policies, these practices that are a part of our even cultural and our societal norms. And when we start to think about how this manifests in tangible ways, we can look at folks who do not have access to adequate education, having lack of access to adequate, affordable healthcare, and even, of course, when we think about the environment, communities that are overburdened by pollution, whether that be air pollution or contaminated drinking water. And so all of these issues compound themselves. They're cumulative in many ways, and they're acting on the very same communities that are already so vulnerable. And I think there's a space to be thinking also about history and the layeredness around our policies, especially with redlining and segregation, and the ways that that also perpetuates this type of structural racism we see today. Whole communities were relegated to areas that were dilapidated in terms of resources, in terms of receiving upward mobility. And so again, we see this manifest in very tangible ways, especially when we look at our health, which we'll talk about today. So with that introduction, I'm going to go ahead and turn it to Charles. I want to ground us especially in what we've already spoken about with Dr. John Balbus and climate change. We know that structural racism is not invisible, and we're also facing a climate crisis that is exacerbating environmental injustices and also creating new and unique challenges. Can you describe for us the role that the environment plays, as well as racism, as we seek to tackle climate change, and then what is being done by the EPA to address these issues?
Well, thank you, Michelle. And first of all, Thank you to the Bloomberg American Health Summit for inviting me here today. It's really an honor to speak with all of you. Let me just begin by focusing everyone's attention on President Biden's Executive Order 14096, which is on revitalizing environmental justice for all. And I think the thread that really animates the executive order is structural racism, or the legacy of racism, cumulative impacts, climate change, and systemic change, and whole government approaches. And I think that's a lot in there, but I think that's the thread that runs through it, and it's a really important way of thinking about this. So let me back up a little bit, and Michelle gave you a lot of background on structural racism, but I wanted to point out the recent work that's being done around structural racism, particularly redlining, which was a banking practice that segregated communities of color in certain areas and resulted in systemic disinvestment. And environmental health outcomes. So recently, there's been about, I think up to now, 50 studies that focus on the relationship or the correlation between redlining, the redline communities and negative environmental health outcomes in terms of PM 2.5, location of power plants, in terms of cardiovascular disease, food deserts, mental health, and urban heat islands, so and many other things. So, so I think the reason why there's been so much attention on this, and redlining is but one example of structural racism, is because of the work of the Mapping Inequality Project at the University of Richmond. That was a partnership between University of Richmond, Virginia Tech, and Johns Hopkins. And that obviously, it produced the digitized maps of the redline areas for about 230 some cities. And of course, what that did was to bring forth the kind of quantitative information and the ability to visualize these relationships. And so going a little bit deeper into that, you know, one of, I will note that the historian Ladale Wingling from Virginia Tech called redlining the Rosetta Stone for the spatial organization of American cities. And if you think about it, what is environmental justice but the spatial distribution of environmental burdens and benefits? And so it's really kind of interconnected. The other thing that's really important to point out is that when you think about these relationships, they're intergenerational. You know, we all know about epigenetics, and we know that this really speaks to why these health disparities are so persistent and so hard to address. So what is happening today? I would just start by kind of noting that, you know, being one of the people that helped give birth to environmental justice about, I don't know, 40, 50 years ago, today is really a new day. And this is, you know, this examples of this are the fact that the amount of money that is being allocated for environmental justice is now in the billions of dollars. EPA has several $billions of funding for communities to address environmental justice. A couple of years ago, $1 million a year for the whole country was a really big deal. So this is the kind of unprecedented change. And through it, we can reshape the relationship of overburdened, historically marginalized communities to government, both at the federal, state, local, and tribal levels. And so that's just one example. A second example is that EPA, for the past 50 years, EPA's principles for how we accomplish our mission is follow the science, the law, and transparency. And in 2021, Administrator Regan added a fourth principle, which is to pursue justice and equity. We also, EPA also elevated a couple of boutique offices, like the Office of Environmental Justice and the Office of External Rights, which enforces Title VI of the Civil Rights Act of 1964, among other things, and made it into a national program on the par of the Office of Water or the Office of Air or the Office of Enforcement. And lastly, I just want to point out, so we're trying to address in new ways how we deal with cumulative impacts. The fact that overburdened communities have these multiple stressors that include environment, health, climate, quality of life, and social factors, the social determinants of health. And so one example of that, I think, is an effort in Chelsea, Massachusetts, where they're overlaying redlining maps over the maps of locations of fuel storage tanks and sea level rise. And that's just one example, I think, of how climate is becoming more and more of a factor in the way that we have to deal with these issues.
Thank you so much, Charles. And yes, thank you. That was amazing. So I know we have some limited time, and I want to just leave us with a few thoughts and then also get final thoughts from you, Charles, as well. I think that, as we were listening, I was listening backstage to Dr. John Balbus. He named that if we're thinking about climate change, we're thinking about those who can adapt, those thinking about mitigative efforts, but also those who are suffering. And I think what you just named, Charles, around the communities that are already so vulnerable and all the ways that I named earlier, in ways that many of us in this room today we're all public health practitioners, so we see this in our own spaces. And so it's really that last piece that around, I think, also the suffering, that we have a space and we have opportunity to be able to help to ameliorate, to help to improve. And when we, again, are looking across what are efforts within the environmental space, especially with what Charles named with the Environmental Protection Agency, we're seeing historic numbers around the resources that are going directly into communities that are being impacted, communities that know their own stories and that know the data and are just looking for the opportunity to be able to address and solve these issues. So I would just say, as we're thinking about the rest of the summit, it's pretty early in the morning, which is nice. Let us think about the ways in which, again, structural racism, our environment, all of these ways do permeate the kinds of spaces that we all inhabit, that we all are a part of in our society, and have these conversations. So I'm gonna leave it to you for the last word, Charles.
Thank you, Michelle. And I just want to end by looking to a quote that I was quoted on the American Public Health Association's Environmental Justice website, and let me make sure I get it right. So I said that for far too long, people of color, Native American, and low-income communities have suffered disproportionately from the devastating consequences of pollution, climate change, and other environmental health harms. Today, under the Biden administration, the nation is finally taking substantial steps to right these wrongs and eliminate health disparities. So I ask you to join us in advancing this exciting era of truly transformative change for environmental justice and civil rights. Thank you.
Okay, so it's my privilege to also introduce our next session. So we'll be learning about a new research project supported by the Bloomberg American Health Initiative on traffic lane width and safety. So we'd like to acknowledge Dr. Shima Hamidi, who's here with us today on her efforts on this project. Thank you.
There's a growing demand for safer walking and biking options across the US, but identifying cost-effective solutions remains a challenge. Dallas, one of the largest cities in the nation, only has 5 miles of protected bike lanes. And in New York, one of the most bike-friendly cities in the US, only 8% of streets have dedicated bike lanes. Yet, there is an unexpected solution to enhancing bike and pedestrian infrastructure: narrowing travel lanes. Using a national database of more than 1,100 streets, our goal was to find the optimal travel lane widths that would increase public safety by minimizing car crashes and maximizing opportunities for biking and walking. When comparing 9 and 11-foot lanes, we found no evidence of increased car crashes. Yet, when lanes increased to 12 feet, so did the risk of crashes, most likely due to drivers increasing their speed and driving more carelessly when they have room to make mistakes. In lanes at 20 to 25 miles per hour speeds, lane widths did not affect safety. However, in lanes at 30 to 35 miles per hour speeds, wider lanes actually resulted in significantly higher number of crashes. And finally, narrower lanes accommodate more users in less space, which means using less asphalt pavement, less land consumption, and smaller impervious surface areas. Here are our recommendations for how city leaders can improve these roadways for pedestrian, cyclist, and driver safety. When establishing lane width standards, setting a context-appropriate driving speed is the best place to start before determining the appropriate lane. Next, city leaders should consider an inclusive and comprehensive street design, factoring in pedestrians, cyclists, and the area's needs, rather than prioritizing driving speed and traffic efficiency for vehicles. Also, in urban areas, set a standard lane width of 10 feet and have engineers justify why it needs to be wider. Currently, in most states, the standard starts at 11 or 12 feet. For streets with heavy freight delivery, transit traffic, and snowfall, we still recommend lane widths of at least 11 feet. Finally, complement lane width reduction with a lane repurposing program to get the best use out of the extra space, such as adding a buffered bike lane or wider sidewalks. By narrowing travel lanes, city leaders can improve safety, optimize sidewalk and bike lanes, reduce environmental impacts, and boost economic activity.
The Bloomberg American Health Initiative works with Puerto Rico's Department of Health to provide funding for their research on suicide prevention. Bloomberg Fellow Maria Cos shares more on her work in the violence focus area.
My name is Maria Cos. I am a clinical psychologist and suicide prevention consultant at the Commission on Suicide Prevention in Puerto Rico's Department of Health. I collect suicide morbidity and mortality data and publish monthly statistical reports. I also offer suicide prevention related trainings and offer technical support in the implementation of suicide prevention protocols, which is a public policy in Puerto Rico. At the Commission, we're proud of the relationships we've built. Over the past few years, we've partnered with health workers, schools, universities, and faith leaders that want to bring mental health awareness and suicide prevention efforts to their communities. Data is the backbone of our efforts. It guides us towards a better understanding of the disproportionately affected populations in our archipelago. As a Bloomberg Fellow, I've been able to connect with and learn from other clinicians that have adopted this public health approach to mental health. I'm honored to be part of the Bloomberg American Health Initiative and to share the work we're doing in Puerto Rico to address mental health needs and bring suicide prevention to the forefront of public health.
Please welcome co-founder of the Brittany Clardy Foundation, Lakeisha Lee, and Bloomberg Assistant Professor of American Health at Johns Hopkins Bloomberg School of Public Health, Dr. Tiara C. Willie.
All right. Good morning, everyone. Right now, call back. My name is Tiara Willie. I'm a Bloomberg Assistant Professor of American Health. My work primarily focuses on the implications of gender-based violence in order to develop interventions that not only prevent violence, but also improve the mental sexual health of survivors. I'm here today with Lakeisha Lee, who is the founder of the Brittany Clardy Foundation. Just for a little bit of context, you may have seen recently in the news this raising crisis of missing and murdered Black women and girls. In the past year alone, we estimate that at least 40% of girls and women who have gone missing have been identified as Black. And what we've known is that this is actually a problem that's been going over for many, many years with very little discussion. And one of those women actually was Brittany Clardy, Lakeisha's sister. So I'm going to give the floor now to Lakeisha so she can talk to us about her foundation and share her story.
Good morning, everyone. My name is Lakeisha Lee, and on February 11th, 2013, my sister Brittany was found murdered in the backseat of her car. Her murderer was later arrested and found guilty of killing not just Brittany, but another young girl named Clarissa Cook, who was trafficked from Georgia all the way to Minnesota. Brittany was a very kind-hearted, loving person who wanted to be close to family all the time. My little sister was the kind of kid who clung to her mom's grocery cart at the store. She didn't even want to go find snacks when the rest of us would run away looking for snacks. She was a planner. She worked with youth every day at Northdale Recreation Center for years as a youth coordinator. So she was a natural nurturer. So the day that my family had not heard from my sister, we called the police right away. We were told, oh, well, she just turned 18. They do this all the time. She probably just ran away with her boyfriend. And we were like, no. We are the experts on our family. We know something's wrong. 2 weeks later, my sister's body was found. The police stuck to the public narrative that my sister was a prostitute, which we adamantly denied as a family. The news media reported it without any evidence. The truth is that my sister had been groomed by a boyfriend that was in his 20s to sexually exploit her. He came into her life when she was 17, during a difficult time in anybody's life at 17. She was struggling in school, hanging out with a different crowd. And later we learned that there was self-harm involved. That boyfriend became very possessive of her and violent. Our family tried really hard to get Brittany away from him, but she was lost. After my sister's passing, we founded the Brittany Clardy Foundation and partnered with 180 Degrees to name the largest shelter for girls who have experienced or are at risk for sexual exploitation in Minnesota, named Brittany's Place. This is not only the first in the state, but it serves girls from ages 12 to 24 without the need for a referral. I am honored to have worked alongside Representative Ruth Richardson at the Minnesota State Legislature to advocate for the first office for missing and murdered African American women in this country. With this success, we started with a task force. After the task force, we partnered with a research team. Dr. Brittany Lewis and her team at Research in Action, they helped lead and co-write a council process and publish the first national legislative report on missing and murdered African American women and girls in the country. I'm here today uplifting Representative Ilhan Omar and Representative Bonnie Watson Coleman, because in the past month, we have now introduced on a federal level the Brittany Clarity Act. Many young women in the United States have the same story as Brittany. They do not get the media attention, the families are not heard by law enforcement, and they're left to feel lost and hopeless. I, as Brittany's keeper, want to bring attention and awareness to those who are left voiceless. I want to amplify their needs and walk alongside survivors with hope for future generations and advocating for change. We must and we can do better. Black women and girls deserve resources for their safety. Historically, Black women and girls have been disadvantaged, but still have overcome tremendous barriers with little or nothing. Knowing this, it should be a priority for lawmakers to support Black women and their families. Because when Black women and girls are safe, all of us are safe.
So Lakeisha came here today to tell us about the translation of her work into federal and also into state policies. And so we can really learn today, as this is a model for other states to adopt this really important commitment to missing and murdered Black women and girls, working with local community-based organizations, with families who have been affected, and also with advocates in order to create an office throughout the US dedicated to these issues. So it's been a wonderful discussion. I'm so thankful for you being here, Lakeisha, and sharing your story. I'm pleased to introduce our next keynote speaker, the Director of the U.S. Department of Justice, Office of Violence Against Women, Rose Marie Hidalgo.
Well, good morning. So great to be with all of you here today. I really want to thank you so much, Dr. Willie, for the introduction, and Lakeisha for your powerful advocacy. I'm grateful to Bloomberg Philanthropies, Bloomberg American Health Initiative, and Johns Hopkins for hosting this impactful event today and inviting me to share some remarks with all of you. Thanks also to all of you attending the summit, both in person and online, for your commitment, your dedication to really looking at all these critical health issues and seeing the interconnection between them so that we can all advance in a more holistic manner ways to address all of these important issues. Addressing and preventing domestic violence, dating violence, sexual assault and stalking, and other forms of gender-based violence is an important public safety and public health issue. The costs and the impact associated with the long-lasting effects of gender-based violence place such a high burden on survivors, on children who witness and are impacted by violence, and on communities as a whole. And so we know this requires a multi-level approach at the individual, relational, community, and society level. The Office on Violence Against Women at DOJ has a responsibility of overseeing the implementation of the Violence Against Women Act, also known as VAWA, and fostering a coordinated community response, what we call a CCR, has been a hallmark of VAWA. And this approach really reflects the theme of this summit, the theme being connections. While it might be easier to do our work in silos, we realize that the lives of survivors do not exist in silos. They need us all to be making these connections to do this work in a more comprehensive way. and really be able to provide a more holistic approach. And this coordinated community response recognizes the important role of many different sectors at the local level, whether it's court systems, law enforcement, victim advocates, but also many others providing supportive services, not only to DV shelters, but transitional housing and legal assistance, as well as the critical role of the health sector, child welfare, educational institutions, and many other sectors. But at the same time that we talk about a coordinated community response, sometimes it turns into a coordinated systems response. What does it mean to put the word community back into that? What does it mean to recognize the strengths, the resilience, the courage, the vision, the leadership of survivors, of communities, to make sure they're at the table too? Amazing advocates like Lakeisha and those who have really turned the pain into purpose of seeing how we as a nation go further in addressing these critical issues and preventing and addressing GBV and broadening the pathways to safety, to support, and to healing. Last year, President Biden signed into law the bipartisan VAWA Reauthorization Act of 2022. That's the 5th iteration of VAWA since it was first enacted in 1994, when then Senator Biden championed VAWA, based on and working with survivors and advocates who really brought this issue to the forefront. And so next year it'll be 30 years since the original passage of VAWA. And each iteration of VAWA, every time it's up for reauthorization, has been an opportunity to say what's working well that we need to scale up, where are there gaps and barriers and emerging issues that we need to address, and how do we continue to strengthen the survivor-centered and trauma-informed approach. So this requires centering the voices and lived experience of survivors to ensure that all survivors, including those from historically marginalized and underserved communities, have the resources, the tools, and multiple pathways to safety, healing, and justice, and doing it from a strengths-based approach when working with different communities. Just recently, we had an opportunity to gather in Oklahoma for our tribal consultation, government-to-government consultation with 574 federally recognized tribes, doing so from a position of sovereignty and strength and hearing from them what's working well, how can we be better partners, how do we provide a range of options for safety and justice. And similarly, I was in LA just 2 weeks ago meeting with culturally specific community-based organizations, with prisoner reentry programs, with community violence intervention initiatives, all these different ways that we need to continue to integrate this work. So VAWA's scope has continually expanded, not only to maintain the essential programs, but really to be able to support these kinds of services that can address a myriad of challenges and do more to go upstream and more on prevention as well. That includes also addressing huge issues of economic stability, of housing that we know are so crucial. And I know the Bloomberg Initiative has really been doing important work in researching and lifting up many of these intersections. New protections in the most recent VAWA also addressed other emerging issues. So for example, while advances in technology have really helped strengthen connections, as we all know, and it's great that it allows us to do this in a hybrid way and bring in people who aren't in the room. We also know that technology-facilitated gender-based violence is growing exponentially, and that we need to do more, recognizing that there are those who can weaponize these tools for harm, and in fact are doing so. So this most recent VAWA, for the first time, has a definition of technological abuse. We're funding new resources to have a national resource center on cybercrimes against individuals, including the non-consensual distribution of intimate images and also cyber stalking. And really, how are we better training law enforcement, victim service providers, educators, and others to really address these critical issues that are disproportionately impacting women, girls, LGBTQ individuals, and others. Also, this VAWA, for the first time, has funding to address restorative practices. So what does that mean to make sure that we are creating multiple options for safety and for justice and letting survivors define the kinds of resources and support they need? For the 2023 fiscal year, VAWA appropriations reached $700 million, following an unprecedented increase of over 30% during the Biden-Harris administration to really center this. And we gave out more than 800 grants, a lot of them also national training and TA, and important research and evaluation dollars as well. And yet, undoubtedly, we have much further to go. So similar to the coordinated community response we're trying to support at the local level, we realize we need to improve connections at the federal level and really make sure we're fostering a whole of government approach to addressing this. So we are excited that just this past May, the White House launched the first ever national plan to end gender-based violence, Strategies for Action. And more than 70 countries around the world have national plans to end GBV, but this is the first time at the US level that we brought together more than 15 federal agencies based on the input of stakeholders, survivors, community leaders, all of you on the front lines who are so important. And these 7 pillars in the plan really help set up a roadmap and a framework for us to continue going forward. And so if you haven't seen it, I commend it to you, and we look forward to the ways that that can help us all address this both as a public safety and public health issue. So while we've come a long way, we know we have much further to go. And while the federal government has an important role to play, we realize that we need to make sure all of us at the local and state government level, at the tribal government level, community-based organizations, faith-based, philanthropy, educational institutions like Hopkins and others, that it takes even the commitment of each of us individually to really be a part of changing these social norms and making sure that we as a society can create an environment where everyone can thrive free from violence. We know at the end of the day, it's not just about improving social services, it's about working for social transformation. And so I want to thank you. I want to thank you for this opportunity to provide some remarks and speak with you. I want to thank you for all the ways that each of you play a critical role in moving forward, and I look forward to ongoing opportunities for collaboration so we can share and advance these goals together. Thank you.
Please welcome CEO and lead consultant of the FLIP Project LLC, Antonio Moore, and the Brian and Randy Schwartz University Professor at the University of Pennsylvania, Dr. Desmond Upton Patton.
Good morning, everyone. It's good to see you. So I'm Desmond Patton. I am the Brian and Randy Schwartz University Professor at the University of Pennsylvania. And my work looks at the impact of social media on well-being, mental health, trauma, violence, and grief among youth and adults of color. I'm joined today with Antonio Moore, a 24-year-old Gen Z expert and strategic advisor whose clients include Everytown for gun violence safety. So my connection to this area starts in the city of Chicago. I was following 2 well-known rappers on Twitter, Chief Keef and Little JoJo. And they were beefing, going back and forth on Twitter. And Little JoJo was fed up with the beef, and he posted his exact location on Twitter. And within 3 hours, he was murdered in that exact location that he posted. And so as a gun violence researcher, I was very worried about the amplification of this type of content on Twitter. And so like a good junior researcher, I went to the Canon to see if there was any research, and there was absolutely no research available to us. And so with colleagues from U of C, we wrote the first paper to define and problematize this area that we call internet banging or cyber banging. But my work really changed when I met a young black girl in Chicago. Her name was Shakira Barnes, and she had just been murdered. And the Chicago Sun-Times called her the gun-toting gang girl of Chicago. And they posted her Twitter handle at Taekwon Assassin online. And so with my team from Columbia University, we developed a set of algorithmic systems to then look into her Twitter life to better understand root causes of violence, to understand predictive pathways between text and emoji and hashtags. And we've been working on this problem ever since. Tone, I'm really interested in your story. You're a 24-year-old Gen Z expert. What is your story and connection to violence in social media?
Man, you know, I'm 24. It's crazy you talk about Lil JoJo and Chief Keef. I grew up on them. Like, you know, like the most interesting thing is like, I watched like the streets changed as I grew up in them in East Baltimore. Like as technology started to really come out and be a big thing, like it blended with the streets after a while. So at first it's like the relationship with it changed. Like, you know, back in the day, a lot of people where we grew up under, like, they ain't want to be on camera, no way. If they was doing anything wrong or illegal, kept social media out of it. But since the Chicago thing took off, like back 2012, the relationship with it changed, and now everything got to be on social media, you know. So really, like, seeing it in the streets firsthand, like, I watch a lot of my peers and a lot of people I love die, and you can watch it happen through social media.
Absolutely. You know, we talk a lot about the negativity that we see on social media and some of the challenges that we see with taunting and bullying. Not understand African American English, they couldn't get context, and they would always misfire or misinterpret African American English. And so one of the things that we did is that we created a job for youth. And we call youth not participants, but domain experts. And we hire them like we hire graduate research assistants and work with them to translate context, but to also talk about the ethics of using AI and social media for gun violence prevention. Can you talk a little bit more about why we need youth in this space now?
Man, you know, you can't fix something if you don't know how it works. That's my man Stokey always say all the time, like, you can't fix something if you don't know how it works. Like, for us, this was native to us. Like, you know, the streets, social media, this was native to us. It's something we can really win at. So at the end of the day, like, you know, good people like adults like yourself that can be in these positions and say, like, nah, like, we need y'all. Let's put y'all in a position of leadership, control. Y'all gonna see the best result from it. You know, one of the best things that my company working on, shout out to PN3 Solutions and Mr. Paris, who's in the crowd here today with me, right? We really working to build something, own it, and control it as young people that's going to address a lot of the misfire patterns and a lot of the misrepresentation of the AI machines, because you got to think about it, we ain't build it. So of course, it's not going to be fit to what we come from, but that's where the opportunity coming at, like the company we doing, we taking advantage of that, putting something together, working directly with social media companies to really remove social media as a factor in a lot of this nonsense that's going on, because you know, we losing a lot of real people to this.
Yeah, no doubt. You know, you sharing one of the solutions reminds me of what I heard from young people in Chicago who kept reminding me that social media is life, right? And that we need to understand that social media isn't this virtual thing that happens over here. It is an integrated part of life. And I think that some of the solutions that you're creating understand social media to be integral to how we think about life and how we think about violence prevention. Do you have any other solutions or any other ideas you want to share with the community?
I mean, you know, anybody that's interested in, like, seeing what we building, you know, we got a non-disclosure for y'all to sign. You know, really though, like, but honestly though, like, the thing is, right, like, I tell kids all the time in my hood where I'm from, like, changing my thinking and, like, being the kid they want to work with, not the one they're afraid of, that's always been the most profitable. You know, the thing is, like, unfortunately, what's going on is, like, it ain't intentionally, but it's like we incentivize to keep the bullshit going on. Excuse my language, but, you know, like, Black Death really been something that, you know, been marketed and really been taken advantage of people in my generation where we from. And for us, social media reality, you can't tell an undeveloped mind, like, you know, that's watching something go on through his screen about his dead homie or his dead brother, like, that he can't act off that, like, because that's real to us, especially under 25 and you're not really all the way there, and it's what you understand since you come out the womb. So, you know, honestly, good stuff like you got going on in Chicago, you know, as long as you pay them good, you know, we really gonna bridge the gap.
Thank you so much. Antonio, this has been a great discussion. Please stay with us for a video highlighting a new project supported by the Initiative on Implementing Violence Reduction Councils. Thank you.
My daughter was a senior at Lincoln. She had been on the cheerleading team. She was just a blessing. She wanted to go to school to be a psychiatrist. And the day that my daughter was killed, when I went and got the mail, my daughter had just got her first acceptance letter to Cal State Dominguez for a scholarship to college.
When my 21-year-old son, Jaime Bravo Jr., was murdered, he didn't die alone. They killed me and my entire family. And I went back to work, and my director at the time said, "Bevelyn, how long are you going to continue to help mothers bury their kids? Is there something that you can do before this happens?" And so I went home and I started thinking about that question.
In 2020, the United States experienced a 30% surge in homicide rates, our country's highest year-over-year increase in more than a century. When violence happens, communities are often left asking what they missed and how can they prevent the next homicide and the one after that. The Violence Reduction Council is a new approach to addressing violence in our communities. What's different about Violence Reduction Councils is that they're a public health approach to what has mostly been, up to now, a law enforcement problem.
It starts with a different set of tools than the ones law enforcement uses when tackling homicide. Data is the essential element of good decision-making, and data from different frontline practitioners can give us a much deeper picture of what's really going on. Law enforcement still has an important role to play, but so do many others. At the heart of this public health approach is a new framework for gathering and understanding data that weighs relevant situational factors to give us that deeper perspective.
To create this environment of trust and collaboration, Violence Reduction Councils offer the community a big tent. Each council is led by a neutral convener, many with a background in public health. This person manages the 3 pillars of the Violence Reduction Council: the Criminal Justice Review Committee, which looks at factors such as victim and suspect history and motive, as well as points of missed opportunity for intervention. The Community Service Provider Reviews focus on local knowledge in each case, as well as perspective on violence in the neighborhood and priorities for enhancing public safety. The Executive Committee, the 3rd pillar, is comprised of both municipal and agency leadership, with the job of making recommendations based on the data and then evaluating the impact of these decisions on violence.
Sometimes it's hard at night for mothers, they're crying at night, they're missing their baby. We just want them to know that we're here for you, that it is a long journey.
So when we tell them our story, would you like your mom to be in our shoes? And none of them to this day, and I've spoke with hundreds of youth, none of them have ever said yes. They all say, no, we don't want our mother to be you.
In one city we worked with, we found that non-fatal shooting data has been key to preventing follow-on shootings and homicides. The Violence Reduction Council model in another city allowed law enforcement to design a more effective witness protection program customized around that community. These are the kind of ideas that get shared between our Violence Reduction Council partners and can produce much better outcomes for everyone. In Milwaukee, where Violence Reduction Councils were pioneered, we were able to achieve close to a 50% decline in homicides using this public health approach.
The whole premise here is one of prevention, of being proactive before the homicide occurs, rather than reactive after the fact. Our project, funded by the Bloomberg American Health Initiative, has developed a comprehensive toolkit, data system, and trainings to help communities establish violence reduction councils of their own. Today, there's a new public health approach to violence prevention. Come explore the possibilities and help us advance violence reduction councils across the country.
Hi everyone, my name is Nahali Vishwanath and I'm a Bloomberg Fellow and Policy Analyst at the National Institute for Criminal Justice Reform. Through my work, I uplift community-based interventions and policies within justice reform and violence reduction, such as Group Violence Reduction Strategy, or GVRS. GVRS is an evidence-based strategy that works to reduce homicides and non-fatal shootings through 4 core components. As illustrated in the graphic, these components are data-driven identification of those at highest risk of being involved in violence, direct and respectful communication to those at high risk, provision of intensive services, supports, and opportunities, such as life coaching, and as a last resort, focused supervision with law enforcement. The National Institute for Criminal Justice Reform's work in Indianapolis has yielded incredible results. Since the implementation of GVRS in the city in 2021, there has been a 31% decrease in homicides and a 22% reduction in non-fatal shootings. This is a direct outcome of continued engagement with those at highest risk, as well as a collaborative partnership with the Indianapolis government. Baltimore has also seen major wins since adopting the group violence reduction strategy. Our organization worked with the city to implement a pilot program in January of last year. As of April 2023, the Western Pilot District experienced a staggering 45% decrease in aggregate shootings. And as a result, the pilot program has been expanded to include other areas of Baltimore. These efforts would not have been possible without the support of Michael Bloomberg. Thank you for your time. Before we continue, we are going to pause for a brief 20-minute break.
When you got your arms around me, you always feel so good.
the Johns Hopkins Bloomberg School of Public Health, Dr. Alfred Sommer.
Welcome back. From that energetic buzz, I feel safe in predicting that this meeting is already generating meaningful engagement and connections. That's the buzzword for this meeting, isn't it? Connections. When I was dean of the Bloomberg School, those many years ago, we excelled in traditional academic pursuits, teaching and conducting important public health research. Hopefully, that would change policy and practice. But what we did not do was anchor our work in the lived experience of those working in the trenches, actually engaged in delivering health. The Bloomberg American Health Initiative has changed all that, as this meeting attests. And with that, our work has become all the more impactful. It takes connections. From research to practice to really make a difference. I'd now like to introduce Ellen McKenzie, a close friend and colleague. Ellen is a global leader in trauma care systems and policies. In 2017, she became the 11th Dean of the Bloomberg School of Public Health. Ellen?
Well, thank you so much, Al, for those inspirational words or wise words, as always. And thank you so much for the warm introduction. So we've had an amazing morning so far, hearing from so many exceptional public health leaders. I'm excited to be here with our fellows, our graduates, our faculty, and very importantly, our community partners. I am so grateful to Deputy Mayor Letitia Daraza and President Daniels for also joining us this morning. And while he could not be here in person this year, I am delighted we got a chance to hear from Mayor Bloomberg, who, of course, is the one who brought us all together. Another round of applause for Mayor Bloomberg. We've had a wide-ranging conversations today. We've discussed gun violence, opioid addiction, food systems, and so much more. Across all these urgent issues, we have seen time and time again how connection powers public health. Now, at the Johns Hopkins Bloomberg School of Public Health, our goal is to connect researchers, practitioners, advocates, communities, and policymakers to make change. We recently launched a Center for Global Women's Health and Gender Equity, an initiative that unites faculty across our university with practitioners and advocates across the globe. And very soon, we'll be officially establishing a new Institute for Planetary Health, a venture that harnesses cross-disciplinary expertise to meet the urgent need of transforming our relationship with the environment. And next year, we'll be breaking ground on a new building, a space that's boldly designed to foster greater collaboration across disciplines and departments and provide an open front door to the Baltimore community. In doing this work, we'll be drawing from a model exemplified by the Bloomberg American Health Initiative, an effort that brings public health tools and solutions to challenges across all of society through our partners, our fellows, our staff, and our faculty. I am never more hopeful than when I'm surrounded by the brilliant and dedicated people who work in public health. Thank you again so very much for being here, and thank you for nurturing your own deeper connections with the initiative and with each other. And now it's my great pleasure to introduce our next speaker, Dr. Laura Herrera Scott, a Bloomberg School alum and the Secretary of Health for the state of Maryland. Dr. Herrera Scott has an exceptional depth of experience as a clinician, an administrator, a veteran, a public health advocate. She brings visionary leadership and innovative ideas to her role as secretary. Laura, We are so very proud of you and grateful for your service, and we're so excited to hear from you today. Dr. Herrera-Scott.
Just checking to see if it was morning. Good morning, everyone. Thank you for having me. I'm really excited to be here, and I want to say I was just so inspired by that video. I'm a native New Yorker, came down here kicking and screaming, but now I proudly call Maryland my home, and certainly Baltimore my home away from home. And I also had the good fortune, I'll share, to not only work with Josh and Michelle once, but twice. So thank you for your leadership here today. I also want to give a shout out to the Bloomberg Fellows. There's more than 20 of you, I think 25, working across the state of Maryland, some within our own agency, and what amazing work you're all doing. So thank you for your contribution to the work we do every day. So when I was asked to speak, I was given a little bit of carte blanche of what I would talk about. And so I wanted to talk around behavioral health, and specifically behavioral health for kids. So I'm going to give some facts, some of which you may all know, but want to start with the big picture and then hone in on what we're doing in the state of Maryland. So untreated behavioral health conditions have serious consequences, including impact on life expectancy. Americans with a mental health illness die 42 to 32 years earlier than the general population. Most of that is thought to be due to comorbid medical conditions, but we know that suicide is one of the most acknowledged contributors to premature mortality. Suicide is the 10th leading cause of death for all ages in the United States, and the second leading cause of death for individuals aged 10 to 34. When we think about mortality that's impacted by overdose deaths, life expectancy since 2021 has declined. A lot of that has been through COVID, but also certainly through overdoses. In behavioral health, nationally, Medicaid is the largest payer and provider of behavioral health services. And when compared to privately insured peers, Medicaid beneficiaries with a medical health condition are nearly 4 times as likely to receive inpatient treatment for their mental health condition, oftentimes their initial presentation, and more likely to report that they needed but did not receive mental health treatment in the past year. So when I took over this office in January of this year, that was a key priority and focus. And so I said, okay, let's see what we have in the state of Maryland. And we looked at our claims data. We're a carve-out state. We have a behavioral health ASO that manages our benefits for our state beneficiaries. And I said, let's see what we have for 2021. We also looked at all our grants that we were providing. And we mapped out those services across the state. And I said, I want to look at service type. I want to look at provider type. And what we started to see was, where are all the services that we were providing? Who were we providing the services for? And we did that for the total population. And then I said, I want to see it for kids. And as you can imagine, we have lots of work to do, but we have even more work to do for kids. And so what we saw were there were disparities in access to key services across the state, in part due to provider availability. So we had geographic variation, certainly in Western Maryland and the Eastern Shore. But we also had typical variations based on social drivers of health that disconnect certain populations from care. For certain service lines, especially for children and youth, especially 1915I services, huge gap in our delivery system. And then when we looked at inpatient residential treatment for children with SUD, we have nothing in the state of Maryland. People have to go outside the state for services. We also looked at gender, and we saw that males were more likely to enter services at a younger age, while females enter services in their teen and young adulthood years, and are more likely to use inpatient services and emergency department services. So we set out to say, well, we have to do better than this, and how do we do better? And as we mapped out the services, we started to build what we're referring to as a continuum of care, very similar to somatic health, as you have primary prevention, primary care, urgent care, emergent care, post-acute care, end-of-life care. Behavioral health is more of a scatter plot, I will say. And so we started to organize the services along a continuum of care, not only to figure out where the gaps are, or what we're referring to as white space, but also how do we coordinate care. And when I talk about children, I'm also talking about their families. We know that families are in crisis as we try to manage kids' care. And what we saw, as the data showed, it was really skewed towards inpatient intensive care services. And so we are working hard to rebalance the system of care, move more of that work upstream so children and their families can get the services sooner than waiting for the crisis to occur. So based on that, we're making significant investments in the behavioral health system. We've invested 6.1 in making the collaborative care model go statewide. That is a primary behavioral health care initiative that has embedded behavioral health, and that's a Medicaid program that was tested as a pilot. We are now going statewide, and that will be inclusive of pediatrics. We are investing in $22.6 million to expand our mobile crisis teams, going from 17 to 45 crisis teams statewide, making another $24 million investment in crisis stabilization services. We're also making inpatient investments for our hard-to-place youth, those children that are stuck in the emergency department because we can't find adequate place for them. And we're making many more investments across the state as we look to fill that white space and build a delivery system where everyone can access the care that they need, where they want to access it. And so we've also organized ourselves, and I'll share with you our call to action. Poverty is both a cause and a consequence of unmet behavioral health needs, and we think if we can start to address these behavioral health needs earlier on, we can help to also address the issues of poverty. We absolutely need interagency coordination to ensure the continuum of care is available for all children, youth, and their families. And that starts with the Maryland Department of Health, but also working with the Community Health Resource Commission, the Consortium of Coordinated Community Supports, the Department of Human Services, the Department of Juvenile Services, and most importantly, also the Department of Education. We are also partnering with community and faith-based organizations to strengthen access to care, and we're leveraging and improving upon our existing behavioral health infrastructure to ensure we are maximizing funding. So a lot of work to do. We hope to learn from you all as we build the system of care that we want everyone to have equitable access to quality care, and I want to thank you for having me today. And with that, I'm now honored to introduce our next speaker, Dr. Dora Hughes, Acting Director for the Center for Clinical Standards and Quality and Acting Chief Medical Officer for the Center for Medicare and Medicaid Services. Thank you.
Good morning. Again, my name is Dora Hughes, and I'm the Acting Director for the Center for Clinical Standards and Quality and the Acting Chief Medical Officer for the Centers for Medicare and Medicaid Services, or CMS. I am so delighted to be here today to discuss how CMS is using our traditional coverage and payment systems in Medicare, Medicaid, and the marketplace health plans to identify and foster the connections between healthcare, public health, and the social services sector that can advance equitable solutions to improve health. I thought I'd start with a story that was shared with me by a colleague. It was a report of a young mother in Reading, Pennsylvania, who presented to the emergency department for the 17th time with her 5-year-old son. Always, it seemed, for non-emergent reasons. At this visit, however, through a CMS initiative, the family was screened for social needs. They were found to have housing difficulties, an unresponsive landlord, there was mold in the home, threats of utility shutoffs, including heat, and more. What was different about this visit, with CMS funding, the family was not only screened, but connected to the social service organizations which were able to address their needs and assist them in finding a new home. My colleague reported that every day, the young boy would happily announce, "We're home, Mom," when they returned to their new place. But this is not only a heartwarming story about a young child. I'm sharing this because with their social needs being addressed, the mom reported that she was now able to attend to her own healthcare needs. And for the CMS initiative overall, across the 20+ sites over the 5-year implementation period, there is a statistically significant, an 8% decrease in visits to the emergency departments. And that has implications for quality, patient experience, and financial costs, both to the families, but also to our healthcare system. These are the types of connections that CMS is beginning to support. Community connections, because we know that where our beneficiaries live, where they work, where they learn, and where they age, all can have a profound impact, and in some cases, some may argue a greater impact on their health and longevity than clinical care alone. To be successful, CMS is increasingly beginning to partner with non-traditional, for us, community partners, in addition to or instead of clinical providers. I mentioned the connections with social services organizations in my first example. As a second example, CMS has another model initiative entitled Integrating Care for Kids, or INC. Through this model, CMS is hoping to better address the physical and the behavioral and mental health needs of children, in part by connecting with schools and child welfare services. In fact, one of our quality indicators, how we will judge if this model is successful or not, is the reduction of out-of-home placement or foster home placement of the children being served through this model. A third example would be CMS's recent announcement that in the state of California, CMS has approved a demonstration that would allow for the first time individuals who are incarcerated to receive mental health services in the period just prior to their release, with the expectation that this will help them establish connections to the community providers that can help them address their health needs, stabilize their health, and allow for a more successful reentry to community. This is a connection with the justice system through CMS's Medicaid program. This is so important, as the National Institute on Drug Abuse estimates that the rate of substance use disorders for people who are incarcerated may be as high as 65%. And these individuals are at increased risk of overdose in the first few weeks of reentry. For each of these examples, as you have heard, these initiatives rely on community partners, those frontline individuals who are members of or who have a deep understanding of the communities that they serve. CMS is increasingly connecting and integrating community partners into the broader health system, and we are systematically pursuing additional opportunities for doing even more so. Just last week, CMS finalized separate coding and payment for community health integration services, which include person-centered planning, care coordination, promoting patient self-advocacy, and facilitating access to the community resources to address unmet social needs that interfere with the diagnosis and treatment of our beneficiaries. Community partners are specifically included in this rulemaking. As one specific example, CMS will now be covering peer recovery counselors or specialists as part of our multi-pronged strategy to better address the behavioral health needs of our beneficiaries. In the months ahead, CMS will continue to incorporate non-traditional approaches into Medicare, Medicaid, and the marketplace to improve the health of Americans. Across our programs, we serve 160 million Americans, about 1 in 2 Americans, and thus we have a special responsibility and accountability to the American people for the work that we do. And thus, CMS will continue to expand and innovate and leverage creative approaches wherever we can to improve access to care and health outcomes. And this will include making connections between clinical providers and the range of community providers. I am eager to hear the additional ideas and recommendations that come forth from this summit. And I ask that you consider CMS a true partner in the work that you do in the days ahead. Thank you for your time today. And now we'll move into the next focus area, addiction and overdose. But first, let's take a look at this video featuring Bloomberg Fellow Fatoumata Mima Kaba. Thank you.
I'm Fatoumata Mima Kaba, and I'm an administrative assistant for the Boston Public Health Commission's Recovery Services Bureau. I support day-to-day operations for our Transitions program, which is a short-term, evidence-based treatment program for adults that focuses on relapse prevention, behavior modification, interpersonal development, and resocialization skills. I help with program management, coordinating donation pickup and distribution to clients, ordering program supplies, and assisting the clinical team. Working with clients and supporting them through their hardships and also celebrating their victories has been one of the most important connections that I've made within my community. And by partnering with other community organizations like BPHC's Homeless Services Bureau and community partners like the Phoenix Gym, we can offer a variety of support and resources beneficial to their recovery. Being a Bloomberg Fellow allows me to deepen my understanding of public health and collaborate with other local organizations to expand recovery and treatment services. Paired with my experience and working alongside my colleagues, I am able to contribute to the addiction crisis in Boston in a meaningful way.
Please welcome Executive Director of On Point NYC, Sam Rivera.
That wasn't a cool New York walk. That was a torn meniscus walk. How you doing? No, you're not supposed to respond. No response. New York, how you doing? Just hello. Just nod your head. You don't say anything back. Usa Mauka, good morning. Good morning in my native language of Taino people. Taka Sam Rivera, I am Sam Rivera, and I wish everyone in this room abundant blessings, Sanako Kakona, to everyone in this room. It's a blessing to be here, it really is. I think about my journey, and I look at the title, Reclaiming the Movement. It couldn't be a better time to have that title. First of all, well, second or third of all, there are so many harm reductionists in this room. Like, how did that happen? That's freaking cool, man. So many. So reclaiming this movement is big. Early 90s, 90, 91, 92. I was like 12 when I started, maybe like 11 and a half. And it was the beginning of this. We didn't have harm reduction. We didn't know what harm reduction was. What we were doing was moving in this beautiful way of taking care of people, who people thought were different, specifically gay men to start with, and then injection drug users, and then all kinds of people, primarily people of color in addition, and no one loved them, and no one wanted to take care of them, and no one, you just saw them as dehuman, right? It saw them as unworthy. And I was blessed as a young man to be a part of ACT UP. Please applaud ACT UP. And it was the most beautiful time in my life where people from all walks of life just loved each other and took care of each other. The hardest part were the deaths. We would see somebody at a meeting one day or at a rally, and they wouldn't be at the next one, and then we'd go to their funeral. But what came out of ACT UP, what came out of that time in HIV and AIDS, early HIV and AIDS, was this thing today we call harm reduction. In my early days, we would go to a shooting gallery, and we would, I lived on the Lower East Side of Manhattan, and we would go there and go to an abandoned building and clean syringes out of a bucket, using bleach and water. I was really blessed during that time, and still blessed today, to have the most amazing mom in the world. And my mom was a nurse on the Lower East Side for 41 years. And as a mama's boy, a proud mama's boy, I would visit her all the time at the hospital. And one day I went there and she was helping this guy, a guy who was using drugs, and she was helping him every day. And I said, Mom, why do you keep helping him? He comes all the time. He doesn't care about himself. And she said, my job as a nurse is to help him until he's able to help himself. And that stayed with me for all those years. But I was cleaning syringes, just trying to help people stay alive, and people thought what we did was absolutely crazy. I was also stealing syringes. So I can say that now because my mom retired. But, and this Dr. Baruzzi, who I really loved, years into my work, one day we were sitting there, he retired, and he said, I remember when you used to come in the morning with your mom, and then you would walk off, and you thought I didn't know you were stealing syringes. So I give him a lot of credit for being a part of the harm reduction movement in his way. It's sad, but it's great that we have this movement back and we're reclaiming it in the way we're supposed to. It is ours. It is our responsibility to take care of people who people see less than. It is our responsibility to love on people until they're able to love on themselves. It is our responsibility. As Bloomberg said, it is our responsibility to stop having politicians make life-saving medical decisions. It is our responsibility to do that. It is scary when I look at it in that way. In my 30 years of this work, or 32 years of this work, I'm kind of tired of allies. Like, if you want to be my ally, that's groovy, like clap from over there, right? But I need some accomplice. Like, I want people who want to get down and do this the way we're doing it. We were blessed to open the only 2 OPCs in the country for the first time, coming up on 2 years. And if you don't applaud for that, I'm going to be very angry. The reality of us opening the OPCs is not about us. It's about everyone who's ever lost anyone to an overdose. It's about everyone who's done this work. Everyone who's ever worked in harm reduction should celebrate that as their success. It's not On Point success, it's everyone's success. My earrings, I am wearing 2 souls. These are 2 people who were saved, who overdosed, and their overdose was reversed by using the naloxone I wear on my ears today. This is what we're doing. This is what this movement is. This is what makes me excited about what I see in this room. So all you folks who are a little older, please excuse me for 10 seconds. I am really excited about the young folks who are into harm reduction. I am really excited about the young folks who are getting radical, right, and righteous and doing things differently. I feel confident as to where this work is heading. And I'm looking forward to coming back when I retire from my motorcycle trip or something and visiting sites and watching you young folks run this thing the way you should and changing it for the better. It is clear that there's no war on drugs in this country. There is not a war on drugs. There's a war on drug users. In fact, there's a war on specific drug users. My time's up. So lastly, there's a war on specific drug users in this country. Specific drugs are allowed to go into specific neighborhoods. Those people in those neighborhoods use and sell those drugs and then are punished for doing so. And we call that a war on drugs. There is no war on drugs in this country. Thank you for this opportunity. Thank you for giving me time to be up here. Blessings to my mother, the greatest woman on the planet. And I'm going to introduce a couple of my friends who are coming up next. So thank you so much. I'm honored to introduce our next discussion, which will focus on addressing the overdose epidemic in indigenous communities. Please join me in welcoming Bloomberg Fellow Philomena Quebec and Clinton Alexander, 2 very good friends of mine. Welcome them to the stage.
So Buju Indinwe Manidug, Babiwash Indigenous Kaz Mukwan Dode Mushkaziving and Donjaba. My name is Philomena Kabak. I'm a Blomberg Fellow with the Bad River Band of Lake Superior, Chippewa, and I'm here with my very good friend, Clinton Alexander, who is the Behavioral Health Director at the White Earth Nation. You're going to introduce yourself too.
Buju Minigijiga Makwami Bisa Indigenous Kaz, Maenga and Dodeum, Gawa Babiganika Gandunjaba. I share that my name is, in our traditional way of saying, I was given the name Brings Hail. I am of the Wolf Clan, and I'm an enrolled member of the White Earth Band of Chippewa Indians.
So Clinton, can you just give us some context? Where is White Earth?
So White Earth is a 60 by 60 reservation, 60 miles by 60 miles reservation in north central Minnesota. We're a few miles from the North Dakota border and about an hour and a half from the Canadian border in Minnesota. We are one of 7 bands that make up the Minnesota Chippewa tribe. We are the largest band with just shy of 17,000 members right now. There are 11 tribes in the state of Minnesota.
So, you know, while we were outside, you were talking about the population trends that you're seeing in White Earth. Can you just share that?
Absolutely. I think, you know, the fight that we're talking about right now in terms of overdose and the loss of life that we have seen in the last decade and the continued, you know, I mean, it's almost a straight up shot right now in our race rate disparities that are occurring. What we're seeing is Minnesota tribes have seen this for a while. Our membership numbers continue to decline. And right now our death rates continue to outpace birth rates. So just in the last 5-6 years, we've seen that number drop from 18,000 down to 16,000. During COVID, we saw quite a few fatalities, and if I start diving into numbers, I'll go down a rabbit hole, but it was pretty dramatic in that sense.
So, you know, both of us really wandered into public health as a result of a community-led, organic, informal needs assessment happening on the ground where our communities were showing us that the needs of people who use drugs were not being addressed by the systems in place. And White Earth has engaged in some really innovative programming to fill these needs. Can you just talk about that a little bit?
Absolutely. I'm fortunate that I sit in the seat today as the Director of Behavioral Health. I have just a little over 400 employees. We have 12 departments. We're throughout the state. When I first started in this work, it was through a volunteer process with my sister, who was doing some work around domestic and sexual violence. And one of the tasks that she assigned me was to talk about HIV and sexual assault, and I never saw that connection, right? So I really started there, and we started diving in, and we saw that intersectionality, and this was almost 2 decades ago. We saw the number of women that we were working with start the HIV rates, the number that were involved in overdoses themselves. The movement that we were working towards really was led by our women for that reason, the survival of our people. And in fact, when we were doing some of our early work around overdose, I'll always remember the community we were in when one of the women from the community said, "There are no more men left in our family. I have lost all my children to either overdose, and the one surviving male is incarcerated for the rest of his life." And in our traditional way, that's how our clan systems are passed down. And we saw that loss happening like that. We also saw, you know, the Super Bowl Sunday that, you know, the nation was talking about Philip Seymour Hoffman. His passing caught everybody in the country by surprise. We were having dope talks in our community because we were burying 3 members that weekend. You know, we saw that disconnect and this continued fight. And a lot of it it's individuals caught in those intersections. And I think that's truly the biggest issue we continue to face.
Absolutely. And you know, some of the things that I find so exciting about the work that White Earth is doing is the weaving of traditional Ojibwe healing methodologies with evidence-based strategies.
Yeah, that's truly, like I said, I sit in this amazing seat. You know, in the last 10 years, we've seen a lot of innovation in White Earth where we've taken the cultural foundation, traditional healing, you know, our cedar ceremonies, things like that, and our programs are based off that. But then we've got that network, or that framework of CMS regulation, because we are a 638 tribe where we have contracted to take on delivery of healthcare systems for our people. which is really the job that I continue to do today, is how do we continue to honor our tradition, the cultural wisdom that has been passed on for millennia, from time immemorial, right? How do we build programs authentically around that, but then make sure that we have that affinity to the CMS structure and things that we need to continue to allow it to be billable.
And one of the problems that we deal with as tribes is that in order to bill CMS for services and maintain sustainability, we have to operate within state Medicaid plans that are absolutely not set up to work with tribes. And in Wisconsin, what we're seeing is that we cannot bill for peer support services, which is so needed. I mean, you have 40 peer support service people that are billing at the Medicaid encounter rate, providing jobs in the community, and real sustainability. But in our tribe, we're unable to do that because Wisconsin has a completely different Medicaid plan, even though we maintain tribal sovereignty. So these kinds of things are really challenges that we have to deal with still. I'm gonna, in our last kind of wrap up, I'm gonna ask about some inequities. So both White Earth, Bad River, a lot of other tribes are operating syringe programs now in the United States. We have to maintain low barrier services, and so we're not asking for identity. And this means as tribes, we're servicing our whole community. We service the settler population and tribal people because the traditional public health systems are not. But yet, we are not receiving resources and support from the states or the federal government for these essential services.
Yeah, I think that's the problematic side of what we do. You're on the Wisconsin side. Arguably we share a lot of treaty territory. Our people travel together. We know that long bound history. But that is problematic when we see the disparities that exist in the way that states work with tribes. And we've talked about this for the last couple of years, where we see real stark differences. To me, it comes down to that respect of tribal sovereignty. And Minnesota is really good at that. But we still see at the federal level some of that pushback when we talk about the irony of traditional healers being reimbursed at reimbursement rates, things like that, right? Where in Minnesota, we're pretty progressive. We have that support of our Department of Human Services, those that do the state plan amendments. We see, the opportunity for us to really, take on the full, what was the intent behind self-determination, Public Law 93-638. We have that support, we can do it. You cross that imaginary line, and you have that structure.
Totally different. Totally different situation. Yep. And so if we don't have the buy-in from the state, our services are limited. And with limited services, it means that we're seeing really bad outcomes on the ground.
Absolutely. And that to me is the irony, right? I think we talk about historical trauma. We talk about people using drugs for good reasons. We talk about complex trauma and that historical. We may not have been in boarding school, but I know the way my grandmother related to me was because she was in boarding school. She would hesitate to say anything in her traditional language because she would pause and she would kind of wait for that hit because she remembered she would get hit, right? And so I think that's what we got to continually fight for is the loss that we've experienced is manifesting in our today's world in loss of life. And so, to me, it's going back to our culture. It's going back to traditional language. The things that were literally taken from us, beat out of us, killed our people for, stole our land for, and yet we're still fighting that fight to say that our traditional ways are evidence-based. And so,
and when we talk about harm reduction, this idea that, like Sam was talking about, our people who are using drugs deserve respect and care and compassion. That is absolutely consistent with our traditional culture and our traditional values. In the few minutes or less than a minute that we have to wrap up, I'm wondering if you can just take out your magic wand. What are some policy changes? What are some world changes that you'd like to see to turn around these trends?
I would argue two things. One is the decriminalization. I think we need to hit that. It's a no-brainer. And the second, I would say for American Indian people, it's in the United States, Article 6 of the U.S. Constitution, it's already there. treaties are supreme law of the land. We need to honor the treaties. It's respecting our connection to land. It's honoring those things. And I think we would be doing a lot better.
Absolutely. Well, thank you for this conversation.
Thank you.
Miigwech.
Thank you. This is awesome.
Miigwech, you guys. Can we leave now?
Please welcome Health Education Supervisor in the Office of Disease Surveillance for the Southern Nevada Health District, Jessica Johnson, and Bloomberg Professor of American Health at the Johns Hopkins Bloomberg School of Public Health, Dr. Susan Sherman.
Hi, Susan. Good almost afternoon, everyone. I'm really excited to be here today talking to you about harm reduction and talking to you about vending machines in particular and why vending machines are appropriate for your state of Nevada.
Yeah, wonderful. Thank you so much for having me today. So, vending machines, probably many of folks out here in the room have used them at some point in their life. And in Nevada in 2017, we explored vending machines as a strategy for increasing access to harm reduction supplies. And that was important for us, particularly in Clark County, Nevada, where I live, because Clark County is the size of like the state of Connecticut, and so we really needed to think broadly about how to increase access to harm reduction services for overdose prevention. Our data tell us that folks are dying from fentanyl overdose across our communities, so we really needed to identify strategies to meet people where they're at.
It's great, and it's such an important example of harm reduction, which is many things, including bringing schemes to people where they are, work, live, play, so that it's accessible to people. Can you talk a little bit about who operates the vending machines? What are some of the logistics?
Yeah, excellent question. This wouldn't be possible without our syringe services program, Impact Exchange, also known as Track B. We have one in the Las Vegas area. And so it was really important, as I mentioned before, for them to think about how they were going to expand their services across the community. So they manage the logistical day in, day out operations. They're really the implementers of this program. And as the local health department, we help support them with funding, data analysis and data access, and other opportunities sort of based on their requests. Sometimes it's easier if they're going to present to a new site, if they can have public health backing for some of their harm reduction messaging.
Yep.
These vending machines are placed at social service organizations in our community that are both geographically convenient and also trusted by people who use drugs in our community. So like our LGBTQ center, federally qualified health centers, opioid treatment providers, and we have 2 at our local health department locations as well. And then product-wise, they stock the vending machines with syringes, naloxone, safer sex kits, wound care kits, fentanyl test strips, and other things like that.
That's great. Have you been able to look at the impact of these machines?
I'm so glad you asked about that. As I'm sure you're aware, studying impact can be a little challenging sometimes for these types of community initiatives, but we had the opportunity to partner with Dr. Sean Allen, who's maybe in the audience here today, and we worked with Dr. Allen and Impact Exchange on a study that looked to see if the opioid-involved overdoses increased or decreased after implementation of the vending machines, particularly around naloxone. And I wrote this down because I didn't want to say it incorrectly, but the analysis found that in the year following naloxone dispensation, there were 41 fewer opioid-involved overdose fatalities than predicted by the model. So that was really incredible for our community. We were really thrilled by those findings. Yeah, absolutely.
That's amazing.
Yeah. In addition, anecdotally, we've really seen community service providers and other folks come to the table more excited about harm reduction, particularly harm reduction supplies. So we've given out more naloxone in the last year to a wider variety of service organizations than ever before, and those types of initiatives.
it's great to see how one intervention can be the vehicle for other interventions.
Definitely agree.
What about policymakers? How have they felt about these machines in their communities?
Yeah, I'm glad you asked about that. In true harm reduction mode, we flew a little bit under the radar initially, some of that by community, for community, but we've been able to translate this both at the state level in policy and local level. So advocates in Nevada were able to change laws to expand access to drug checking. And then locally, we were able to use these findings at the city and county level and presenting to them about implementation of vending machines in these communities to local elected officials. Some of the work that helped guide this policy was actually, believe it or not, from the forecast study that you worked on around fentanyl test strips. It really helped us to dispel some of the myths about how people who use drugs use fentanyl test strips as a drug checking tool. Can you share more about the impact you've seen from that study?
It's always great to hear that our work is useful, because that's really the point of what we are doing. The forecast study, which was conducted in 2017 in Baltimore, Providence, hello, this side of the room, Baltimore, Providence, and Boston, and we validated several different tools, including fentanyl test strips, to test can they accurately show when fentanyl and other substances were and were not present. We also interviewed people who use drugs to see were they interested in drug checking. Had they used drug checking, how would it be to use these strips before they use drugs, after they use drugs? And I want to say that we knew that fentanyl test strips were being implemented on the ground by a lot of activists, people taking a chance because drug checking wasn't necessarily decriminalized in their jurisdiction, but we thought it was really important to provide evidence that showed that, in fact, these strips were accurate, which is what we found. And it was a time on the East Coast in Baltimore that fentanyl was really the driver. It continues to be, but it was skyrocketing in 2017, the driver of fatal overdoses. And we were happy to find that, in fact, they worked, they were accurate, and we also helped decriminalize drug checking in the state of Maryland, which we were happy about.
Yeah, that's really incredible. So I know that study you mentioned, 2017, are you doing any current work on drug checking?
As you would say, I'm so glad that you asked. We have a NIDA-funded study where we actually have a mobile van going out with an FTIR machine. It's a machine that tests the contents of a substance and can show the relative percentage of what's in the substance and lots of different drugs, including fentanyl. This is run by Danielle Nestat. It's called the Check It Intervention, who was sitting right there before, but I'm lucky enough to work with Danielle. And we actually are going to have this machine to provide point-of-care drug checking. So people can come on the van, bring a baggie, bring a small substance, and within a few minutes see the results and make informed decisions about what they used, what they're going to use. It's an overdose prevention and HIV prevention study, so we also have a mobile nurse on the van, a nurse on the van to provide pre-exposure prophylaxis for people that wanted who are HIV negative, and also to take care of wounds, because xylazine is really now the next substance in our drug market in Philadelphia, other cities. People have gaping wounds. Xylazine is a horse tranquilizer that's not approved for human consumption. It's made its way in the drug market. And so we're really happy to be able to provide wound care in the field.
That sounds really exciting and will yield a lot of important translatable results for many communities. Can you share why this study and others are important to bring policymakers on board to inform humane and evidence-based drug policy?
That's like the best last question. I really believe this, and I've always believed this. As researchers, being so lucky to, for me, being at the Bloomberg School of Public Health, having access to the Bloomberg Initiative, it's our responsibility to conduct really rigorous research that can be consumed by activists, program folks. Like, why else do we do what we do? And there's so many. I really encourage all researchers, no matter if this is your first year or your 20th year, in which case you've probably already done this, work with community advocates. So many advocates have been doing this work already for so long. Oftentimes, we're not working with them yet, or we think we can't approach them. I bet Sam can attest, researchers can be useful if you work in partnership, and it really is our responsibility to do that.
Yeah, I absolutely agree. I think identifying strategies to translate this work can help others help inform these evidence-based policies and support folks like me at a local level in working with our communities to translate the findings to more evidence-based drug policy and work.
Thank you.
Thank you. Brendan?
Yes. So it is now my great pleasure to introduce my colleague and dear friend, Brendan Saloner, who's going to magically appear over there to talk about some of his work.
Naloxone saves lives after an overdose, but it often leaves people feeling disoriented and sick. They may turn down a trip to the hospital when the ambulance arrives. In Camden, New Jersey, a team of emergency medicine providers asked whether it would help for paramedics to provide the medication buprenorphine, which is usually used for long-term treatment, immediately after naloxone. Treating patients with high doses of buprenorphine after an overdose had already been proven to sharply decrease the likelihood of future overdose when given in the hospital. But the same procedure had never been tried in the field. In partnership with Cooper University Hospital, including Bloomberg Fellow Matthew Salzman, we studied the rollout of the first ever buprenorphine-equipped ambulance. We compared the results for patients who were offered naloxone plus buprenorphine to a control group of patients who were treated by ambulances that offered naloxone alone. Ambulances in Camden are dispatched based on proximity to the call, so whether patients got access to the new protocol was like flipping a coin. The results were striking. Patients treated with the buprenorphine-equipped ambulance experienced a dramatic reduction in post-overdose withdrawal symptoms. Compared to the control group, these patients had almost 6 times the odds of following up with a bridge clinic in the 30 days after overdose. The buprenorphine-equipped ambulance model has now spread across the US and to Canada. No single intervention can turn the tide of the opioid crisis, but adding new touch points to help patients in crisis can be transformative. The challenge that lies ahead is making sure all people can get help when they need it the most.
This year, the Bloomberg Fellows Program welcomed its first ever farmer. Let's hear from Kelsey Crawford about her work in the food systems for health focus area.
I'm Kelsey Crawford, and I'm a farm manager at Tumbling Shoals Farm in rural Appalachian, Wilkes County, North Carolina. We're a 3-acre certified organic vegetable farm that serves over 1,000 families per week through 4 farmers markets, our farm share, and multiple food bank collaborations. So we feed a lot of people. Tumbling Shoals Farm is a cornerstone in our community because of our high-quality organic produce and innovative food justice initiatives. As rural Appalachian farmers, we're all about making connections, finding ways to feed more people, and supporting the workers who grow our food. We write grants to cover the costs of deliveries to local food banks, run a community-funded low-income farm share, and mentor new farmers through Blue Ridge Women in Agriculture. Through my Bloomberg Fellowship, I've added researchers, policymakers, and other experts into my network. As farmers, when we need help, we ask our neighbors, and now I have an even larger group of neighbors to turn to. During the COVID-19 pandemic, my community showed a lot of resilience and was able to find new food pathways. But it also pointed out inequities, and it made me want to gain the technical skills to analyze our food environment and create sustainable systems for the future.
Please welcome Executive Director of the New York City Mayor's Office of Food Policy, Kate McKenzie, and Research and Evaluation Strategy Manager at the New Jersey office of the Food Security Advocate, Dr. Jenny Shrum, for a conversation moderated by Built Environment and Food Systems Coordinator for Boulder County Public Health, Rachel Arndt.
Great, thanks for joining me today, Kate and Jenny. We've heard a lot about connections today, both between the food system and adolescent health, as well as the food system and environmental challenges. I'm just wondering if you could talk a little bit about how your work connects to these areas and just share some of the challenges with us.
Sure, thanks so much. It's really a treat to be here. So New York City Mayor's Office of Food Policy supports 10-year food policy plan called Food Forward. And what that plan did for us was take the multifaceted food system and provide us with a roadmap for addressing not just one issue about what we eat, but the myriad of issues that our food system is connected to and that a city government can contribute towards. So whether it is thinking about the 230 million meals a year that we're serving to New York's most vulnerable, those include our public hospital system, in which plant-based meals right now are the default in our hospital system, our school system, which is the country's largest, that offers plant-powered Fridays and meatless Mondays, and the power of meal procurement that offers us, which is very closely connected to our next priority area, which is around food and climate. And I'm so gratified to see this summit really centering food and climate also. We support our watershed with best management practices in agriculture, and that's food policy, right? So making sure that some of our farmers are using the absolute best practices to protect our watershed. And then also, I would say, food education. We have a plan for all of our public schools to not just make sure that what we're serving in our cafeterias is delicious and healthy, but also to make sure that kids understand why we're putting great food on their plate. They understand how certain foods are marketed to them in ways that are causing them and directing them to make a not so great choice. And also just really understanding where food comes from, how it gets to the grocery store, how it gets into a package, how it is grown quite literally from the ground and making its way onto our plates. These are just some of the issues, but I think the challenge here is making sure that we can have a good balance of depth as well as the breadth of the work. And I think, having a mayor like Mayor Adams that is centering food across everything that we do provides us with a great platform for that.
Thank you. Jenny, what about your work in New Jersey? Can you tell us a little bit about the key food systems issues that you're working on?
Sure. I saw a lot of New Jersey stickers out there. Say hello to my New Jersey friends. So in New Jersey, we recently, we're about a year old, started the Office of the Food Security Advocate. And what's really exciting about the office is we are within the governor's office, and it's an opportunity to serve as a collaborator between all the departments in the state. And as you can imagine with food, there's such a spectrum of programs attached to it. Some collaboration between all the departments that run different programming is really essential when we're thinking about a more holistic adoption of what food security means. And when we think about food security, a lot of times we will think about anti-hunger organizations, food pantries, food banks. We'll think of federal food benefit programs, so the welfare system, thinking about SNAP and WIC. And then we also have the food system and producers, consumers, retail, corporations. So all of that and the spectrum of that can make decision-making and priorities very difficult. So to get people in the same room and talk about what real food security means, which is not only economic access or physical access in our environment, but what types of food are offered? Are they culturally appropriate? Are they stable over a long amount of time? Do people have decision-making power in their food system? That's a really important piece of feeling that you have appropriate access to the foods that you need. So the office is really excited to steward those conversations and approach it I think the way I view it, with a bigger table, we need more people to come to the table to start figuring out some of the common challenges I'm sure we all see day to day when we're talking about a lot of people in very dense states, right? Diverse populations with a lot of different food needs.
Yeah, you both, I think, really hit the nail on the head with how multidisciplinary food systems work really is, and how a definition of community can really look differently. So, Kate, in your work, that the community that you're working with are government offices, and same for you, Jenny, but also working with community members as well to give them a voice. I was just wondering if you could talk a little bit more about the role that community plays, or organizations, in helping to shape the policy efforts that you're working on.
Yeah, you know, I think about where I grew up in the middle of Pennsylvania, and there was a very sort of like clear community. And then having lived in New York for more than 20 years now, you know, I think about, you know, how challenging it is when we come to, you know, researching and statistics, right? There's often one statistic that tries to represent the entire city, and nothing could be farther from the truth. And so the focus that this administration has on equity, to look at the deep layers of boroughs, right, or of neighborhoods, to find out how we can really support true community evolution and development as it relates to policies, right? And some of that, you know, like one policy might be working quite well in one area, but needs some adjustments in another. So being able to be nimble and flexible to the needs of different communities. I love that you raised, you know, the points around culture and ethnicity. When it comes to food choices, it is not one size fits all. And being able to be responsive to that and bring in the cultural flavors, the sensitivities, and traditions is a really important place for community. So for us, it's about representing and ensuring that equity is driving the evolutions and the creations of our policies.
So we are starting some really exciting research projects, and with those, they've been really intentional about incorporating community in defining what success means for them when it comes to food security. And also, a lot of what we're trying to do is have everyone come to the same understanding about what data means and what it doesn't mean. Data can be messy, data can have a lot of limitations to it, but it doesn't mean we should avoid it. It's also a tool to help our understanding. So a lot of that is just having conversations right now about what is data, why is it helpful, how can we take some fear out of it, and have it used as a tool. And I think something that I wanted to add when we think about, you know, equity in it is also equity in terms of longevity of our food system. Are we using farming practices? Are we building up a food system that's also going to be equitable to future generations, right? Are we just taking easy steps now, or are we being really thoughtful and mindful about other generations that are going to be relying on the food system?
Yeah, I love that. I'm wondering, as we start to think about wrapping up our conversation, if you could just talk about what's on the horizon for your work and what you see the future of this work to look like.
Speaking of longevity, we have last week released Healthy NYC, which is a plan that Commissioner Vassan has, with support obviously from all of our fellow commissioners. We've experienced a decline in longevity as a result of the pandemic. And whether that is from, you know, overdose, whether that is from the challenges around mental health and suicide, but also around chronic disease. And so from the Office of Food Policy, we are helping our health department to drive down deaths relatable to chronic disease by 5% by 2030. And this is all in the spirit and goal to have a longer, healthier, more fulfilling life. And so as we continue, actually, I think the legacy that Mayor Bloomberg really started with our food standards, with some of our trans fat bans, how we're really focusing on the upstream solutions and treatments to address chronic disease is part of our next frontier.
That's great. I totally agree with so much of what you said, and I think we're really excited to play that collaborating role. You know, our office is not necessary to create notes, to celebrate strengths and good work that people are already doing. And when we have all those players at the table, one conversation we're really trying to steward is thinking about stigma and bias in our food system also, and those who the way we rely on what is available and accessible, making sure that it's really approachable, because we want people to be tapping into the resources that exist as much as possible to make sure we're uplifting the food system in a healthy and holistic way.
Great. As we wrap up here, just any additional challenges or lessons learned that you want to share from your work that may be applicable to fellows in the audience?
I think when we think of the challenge, who's not challenged in what they do, and looking at that more really from an opportunistic place. And I think, as we consider, the sort of really challenging statistics that are coming out of DC around food insecurity, and thinking about that not just from a place of making sure that people are fed tonight, but making sure that we are looking at the systems and the structures that are resulting in food insecurity and in poverty. So, for us, I think some of the greatest challenges that can also be reframing how we consider some of these problems. And so we have some programs that are really about affordable food access. In as much as we are also distributing free food, right? We're trying to make sure that all people have access to affordable foods. And so we have a really innovative program called Groceries to Go that provides people the ability to stretch their buying power in grocery stores. Some of the things around technology and home delivered meals that we learned from the pandemic. So I think taking a real close examination at the things that were made possible from the pandemic. Not everything was a challenge, right? But where were we able, particularly in government, to do things quickly with great success, and how do we keep those continuing in these times now that we're experiencing? Because the results of the pandemic we're going to be feeling for years and years and years to come, and our way that we're supporting all people to be able to thrive and again to live their best lives, some of that has to consider the methods and the approaches that we took during the pandemic.
I agree, and I would add, I think what I usually say when I talk about the beauty of public health is, when we talk about food, it's a common denominator across many of us, as many basic needs are. So I think the spectrum of need can seem insurmountable and really challenging, but I think there's also so much strength and innovation in how we can approach strengthening the food system. So I think we should be really open-minded to some of the creative programs that people have in mind, and thinking about what's valuable in that conversation, and not just about economic access, not just about physical access, but looking at people as human beings, right? And addressing those needs holistically, I think is a really exciting time for the field and for the sector as a whole.
Great. Thank you both so much. I feel really inspired by the conversation that we've had and focusing on solutions. I'm delighted now to introduce our keynote remarks for the Food Systems for Health focus area, author and journalist Michael Grunwald on connecting climate and food. Thank you.
Thanks.
Food is not the biggest source of climate change. It's obviously second behind fossil fuels. And climate change is not the most urgent issue related to food. It's probably third behind hunger and public health. But the intersection of food and climate is a hugely important intersection that doesn't get a huge amount of attention. It's an area where a lot of people, even people who know a lot about food or a lot about climate, often don't know so much or know things that aren't so. I started plowing into this stuff just 4 years ago when I realized I was one of those people. So I'm going to do a quick food and climate 101. And point one is that our food has a massive impact on our environment. Agriculture is by far the world's leading driver of deforestation, wetland destruction, biodiversity loss, water pollution, and water shortages. It's like a really bad driver. And a huge portion of the problem is animal agriculture, which of course is also a leading driver of antibiotic resistance and could be the source of the next pandemic. And yeah, the food system does generate about 1/3 of all greenhouse gases. So it's still more than transportation or electricity. Even if the world stops using fossil fuels tomorrow, we'll still be on track to blow past our 2050 climate targets if we don't fix our food. So some of the problem is fossil-fueled tractors and crop dusters and trucks carrying food to market and so forth. And some of it, as you've heard, is cow burps and farts that emit methane, and fertilizer that emits nitrous oxide, and manure that emits both. But the biggest problem, and this is point number 2, is a land problem. We're just converting too many forests, wetlands, and other carbon-rich natural lands into agricultural lands. We are eating the earth. You know, the Earth's land, it's divided into developed land, natural land, and agricultural land. And one reason this issue doesn't get so much attention is that most of us spend our time in the developed part. Anyone know how much of the Earth's ice-free land is developed? So we'll do show of hands. We'll do 10, 20, or 30%. How many say 30%? Okay, good. 20%? Yeah, 10%, right? Yeah, well, I'm just messing with you. It's 1%. The Earth is flyover country, right? And it's right now split pretty evenly between farms and nature, but we really can't afford to lose any more nature. We are already using a landmass the size of Europe plus the size of Asia for agriculture. And we're on track to deforest another landmass twice the size of India to feed our population by 2050. That would mean goodbye Amazon and goodbye climate goals. Like I said, fossil fuels are still a bigger problem, but we're at least starting to solve it with clean energy, just not nearly fast enough. We're not even trying to solve the food and land problem yet, and it's actually getting worse. And as climate change makes it harder to grow food, that's going to create even more pressure for deforestation. So point 3 is that the land problem is mostly a meat problem, which sucks, because meat is delicious. More than 3/4 of our agricultural land is used to feed livestock. The Earth is becoming an animal farm. But there's a twist. The meat problem is mostly a beef problem. You can see that very big line at the top. Chicken and pork, they generate more emissions than nuts and peas, and cheese is even a little worse, but beef is way worse than any of them. Partly because of the burps and farts and manure, but mainly because of land use. Beef cattle are inefficient. They use 60% of the world's agricultural land to produce 3% of the world's calories. When you eat burgers and steaks, I'm sorry, but you're basically eating the rainforest. You're eating jaguars and macaws and the rest of the cast of Rio. It's terrible. I know, I'm the climate guy. I didn't get invited to cheer you up. But here's the good news, some good news. Since the 70s, Americans have reduced our per capita beef consumption by 1/3. We're eating way more meat overall because we're eating way more chicken. But cutting back on beef is not only better for our health, it was the most significant thing we did to cut our emissions before the recent rise of solar and electric vehicles. So let me quickly talk about what can be done, because there are a lot of messages out there, right? Eat local, not really. Eat organic, not helpful. Go vegan, yeah, great, but it's not gonna happen. And here's another fun fact. While it would also be great if we all went vegetarian, it would be just about as great if we all just cut out beef, because it's such an emissions bomb, and most vegetarians end up eating a lot of dairy. So point 4 is boring, but the 2 biggest ways to reduce your personal footprint, your food print, are to eat less beef and waste less food. I've stopped eating beef. It's a bummer. I miss it. I relapsed when I did a reporting trip to Brazil, because Brazil. But beef is such an outsized part of the problem. If the world's cattle formed their own nation, it would be number 3 in emissions. And if the world's food waste formed its own nation, it would compete with the Republic of Cattle for number 3. Nearly a third of the food that gets grown never makes it to our mouths. Food waste is the biggest component of our trash. It creates methane in landfills. But the bigger problem, again, is that when we waste food, we waste the fertilizer and the water, and especially the land used to grow the food. We're using a landmass the size of China to grow garbage. So of course, when I say we need to eat less beef and waste less food, I'm saying we need public policy that incentivizes us to do those things. Especially on the food waste side, there's a lot of opportunity. We don't want to waste $200 billion worth of food every year. Beef is going to be tougher. I use that photo because a pollster once told me that government restrictions on meat were the most unpopular policies he ever tested, up there with veterans' benefits for ISIS. So we're going to need individual action as well as collective action, and you know, we do make food choices every day. So I'm really honored to speak about climate at a health conference, because as you know, a hotter world will have some really scary health implications. And the trajectory of our food and climate problem is incredibly scary. Even if we do waste less food and the rich world eats less beef, the world's farmers will still have to produce way more calories on way less land to feed the world without frying the world. Now, I'm just the climate nerd here, so I don't want to get over my skis, but the last point I want to make is that the kind of food that protects nature, the food that avoids deforestation and wetland destruction, is not always natural. And in this area, parts of the public health and nutrition communities have not always been helpful. I'll do two very quick examples. The first is fake meat. I mean, today it's mostly plant-based meat, like Impossible beef, but you're starting to see mycoprotein from fungi. Eventually you'll see cultivated meat from animal cells. All of those options, especially when they replace beef, are way better for the environment and the climate. But you are starting to hear a lot of grumbling about how they're artificial, they're processed food, just eat vegetables. And it would be great for our bodies and the rainforests if we all just ate lentils and kale. But that is not the relevant comparison. And I'm not the nutrition guy, but the early studies have suggested that plant-based meat is just as healthy as most animal carcass meat, and probably a little healthier than beef. And it's going to get better, while the cow is a pretty mature technology. And again, it's not like what's going on in factory farms is all that natural either. So I'm not saying give fake meat a nutritional pass just because it can save the planet, but don't give it a harder time just because it doesn't fit your idealized vision of food and diets. And then the flip side of that is regenerative agriculture, right? We all love regenerative now. Walmart's going to be a regenerative company. Joe Rogan loves it. King Charles loves it. The UN loves it. We all want farms to nurture their soil. And some regenerative practices are great for the environment, but to wildly oversimplify, they're not really great for the climate because they use more land and that means more deforestation. Regenerative grass-fed beef, even more emissions than industrial corn-fed beef. And now again, I'm going to creep beyond my area of semi-expertise, but my understanding is that there's not a lot of evidence that food from the nice Red Barn family farms where the cows roam free and have names instead of numbers, that it's any healthier than the evil factory farm food where the agribusinesses mistreat their workers and rake in crazy profits. And there's a lot of unscientific wishful thinking in this arena, and I don't think regenerative should get a health halo it doesn't earn. So it's too bad. I don't mean to knock on you guys, because I think there's a fair amount of dietary overlap between what's good for the planet and what's good for our health. Just eat a lot of plants, don't eat a lot of red meat, and don't overeat. So I think there's a fair amount of room for, I guess the word of the conference, right, is connection between the climate world and the health world. I just want to make sure we're all starting from a common baseline of facts. So again, to recap, it's not rocket science, it's just climate science. Food has a massive impact because it uses a lot of land, so we need to eat less beef and waste less food that uses land, and remember that what's best for nature isn't always natural. Thanks so much.
Please welcome Bloomberg Fellow at Boulder County Public Health, Amelia Hulbert.
Crawford, and I'm a Bloomberg Fellow at Boulder County Public Health in Boulder, Colorado. My work improves food security for families with low incomes in Boulder County to improve chronic disease outcomes and build healthier food and beverage environments. In 2016, the City of Boulder passed the nation's second voter-approved sugar-sweetened beverage tax, and this tax intentionally dedicates all revenues to health equity. Since 2017, the fund has distributed over $21 million in total to initiatives to improve the community's health. For a town of just over 100,000 residents with a high cost of living, this is an enormous investment into reducing health disparities for historically marginalized populations. This tax funds fruit and vegetable incentive programs that my team implements for over 8,000 City of Boulder residents just with our work alone. Many of these families are households with mixed documented status who cannot qualify for federal benefit programs. We hear consistently that families know what they need to eat healthy and they want to eat more fruits and vegetables, but that cost is their primary barrier. So these programs directly address this barrier. For a community like Boulder, this sugary drinks tax policy is effective in helping people choose healthier beverages while also providing millions of grant dollars for programs that provide families with dignity and choice so that they can purchase foods that are most nourishing and culturally appropriate for them. And now I'd like to welcome Josh and Michelle back to the stage.
Wow. Wow. Just wow? Okay, just wow. You know, I've been thinking as I was sitting there that, you know, our Dean's strategic plan includes the 5 pillars of people and advocacy, science, education, and partnership. And I think today, our Dean will agree that connection would be the 6th pillar of our strategic plan. Well, how amazing of a morning it has been. Okay, Josh, what do you think? Wow.
It's been awesome. Yes, I'm speechless here.
Yeah, me too. I just want to thank our photographers, Larry and Howard, who's been working the room and so inspiring, capturing all of these moments. I want to thank our incredible team at the Bloomberg American Health Initiative again for their continued support and all the efforts in pulling this together.
Can they stand up if they're here? I don't know if they're in the room. They may be setting up for the next thing.
Many of them. Well, we see Shannon in the back.
Yes. We'll get all Shannon. Okay, there you go.
And many of them are in the front. And I want to also thank the Baltimore Urban Inspiration Choir. I want to thank our faculty. I want to thank our chairs and our deans just for the incredible amount of support that you continue to give to the Bloomberg American Health Initiative and certainly to the philanthropies.
Well, we hope the insights and inspiration from today follow you back to your day jobs, reminding you of the time that you spent with us this morning.
Follow you back to your day jobs, like a bad dream?
Not like a bad dream, Michelle. More like a recurring email from NAC. Just keeps coming back.
Okay, and we want to keep the momentum and the connections going by spreading the word about the initiative. We're able to grow our network of partners and certainly our impact.
We'd like to ask you to try to take at least one selfie in front of the Bocce ball. You know what that is? You passed it on the way in. Every time Ellen sees it, it gets trucked out. There's like a team of like 15 people handling it from the school. She says to me, that thing's gonna shatter into 1,000,000 pieces. So you never know whether it's gonna survive another day. So while it's here, you're gonna want a selfie with it. Do a selfie, post it on social media with the hashtag Bloomberg Health Summit 2023.
And for super duper extra credit, take a photo with at least one person from each focus area.
Okay, Michelle, I have a question for you.
Yep.
You ready for a selfie right now?
Sure, yeah.
All right, let's do it.
Right now?
Yep, everybody wants to get in. Come to the middle. Here we go.
All right. You're serious?
I'm serious.
Okay.
We're gonna try it.
All right.
Stand up. We need to fill in the middle here behind us. Let's go. We're almost done. Here we go. Almost. Big smiles. All right, 1, 2, 3. Excellent. Thank you, everybody. Fantastic. So I think we are not quite done, though. We have lunch. We have this afternoon's activities, including a very exclusive screening of The Invisible Shield, produced by Bloomberg Philanthropies. There's still time to register on the Summit app. But before we go, we want one more musical item, and someone bring my violin.
Your violin?
No, sorry.
Not the violin.
Okay, sorry. We are going to welcome back the Baltimore Urban Inspiration Choir.